following as well. But someday, maybe on a holiday, I'll go over there and try and do an EV conversion.
Oh, that would be fun.
Because we're starting to see the like classic sports cars are all starting to come out with electric versions, and it's actually really cool.
Yeah, my son's looking at the electric Volvo, which is really seems to be a really nice car.
Well, if he's a gearhead, tell him to check out the AC Cobra. Was a famous car in the 60s.
Okay.
And the Cobra now they're releasing a limited edition in electric, and it's even faster than the original, and it's just as good looking. You know, 2-seater, completely useless for most cases, except afternoon jaunts, but it'd be fun.
Or taking your mom for a ride, right?
Yeah. Mess up your hair. Okay, so I don't know who's all here. Should we check to see? We've got a lot of people coming on. As for board, I'm looking around here to see. We've got Dr. Kurt, we've got Bill, we've got Jeannie. Tori's here, Ann's here. Does that get us close to a quorum? Should we begin? It does. So
yeah, we do have
yes. So I'm going to call this meeting to order now. Is it? It's 1. Yes, we're ready. And as for a roll call, I think did I just do that? And was that enough for you? Okay, I think we're here. We're going to just keep on moving. I think I want to review previous minutes. If anybody has a correction, if not corrections, an approval of the minutes would be a motion I'm looking for.
I move the minutes be approved.
We've got a
second.
And a second from Tori, Dr. Kurt, and then a second from Tori. All in favor, just give me a hand up, and I'm going to look around here just real quick. Okay, we're looking good. That passes. We're going to get right into general Board of Health business. I've got us back on schedule. And Suzuho, you're on deck. I know Jordana is out for the first part of this meeting, but she'll be joining us later. Is that correct?
That is correct. Yeah. Thanks, Greg.
Okay, go ahead.
Hi, everyone. Good afternoon. So I wanted to start this Board of Health meeting talking a little bit about our organizational structure, our department structure that we were able to get approved by the BoCC a couple weeks ago. So Greg, I apologize. This will be repeated information for you, but for everyone else. If we can go to the next slide, I wanted to provide a little bit of background information. As you might recall, March of 2020, we had 5.25 FTE filled or positions filled within the public health department. So you might recall we had some turnover right before then and some vacant positions. And so we were a pretty small team. And since then, we've been fortunate to be able to really expand our team to be able to support this COVID response effort. So during that time, not all of these positions are still with us, but at different periods of time over the last year and a half, we had brought on 4 temporary staff, which included 2 epidemiologists, the 2 contract employees, included the 2 epidemiologists that we brought on specifically to help us early on in the pandemic before we had hired Josh Vance, and then 15 term limited positions that were hired between June, the earliest being Josh, and then into the fall of 2020 as well. During the last year and a half, we've had some positions turnover, whether because they were temporary or contract employees that were only meant to be with us for 3 to 6 months, or some of our term limited positions have also found other job opportunities and have left Picken County. But we were able to request to the BoCC an extension for those term limited positions. As you might recall, those 15 term limited positions, which is the core of our COVID response team at this time, really came on between June and August of 2020, and we're set to be 18-month term limited positions that are to end in December of this year. And knowing that we have a very busy winter season here in Picken County, we wanted to see if we can extend those term limits to the end of March of 2020, or 2022. Which allows us to have that core support through the winter season, and also allows us a little bit of cushion and overlap with the 2022 positions that we'll be requesting to the board during the regular 2022 budget review process. So I'll go into more of the details around that, but just wanted to give you a little bit of background here. And then the funding sources that we have available to support these positions as well. So we've had the CARES Act from early on in the pandemic, and then we have this ELC grant. We've had 2 rounds of that, close to about $1 million total to support that. And then our COVID immunizations grant, which we've had 4 cycles of, or have received 4 cycles of. We're currently in the 2nd cycle, still spending that down before we move into the 3rd and 4th cycles of those funds. Both of those, the ELC and the immunization funds, go through June of 2024, which is the length of time that the CDC and CDPHE have required local public health agencies to have staffing to continue responding to this pandemic. So the positions we're requesting in 2022 will be for another 18 months again to ensure that we have that staff capacity to meet the requirements going into June of 2024. Next slide, please. So this is an overview of our current org structure. The blue positions are the ones that were previously approved to COVID or were approved during COVID as ongoing positions or term limited positions, but regular FTE within the department. And then this burgundy red color are the COVID specific hires that were brought on. So you'll see on the far left, we have our administrative specialist, and then kind of in the middle, the OWTS permit tech. They're a little grayed out because they're scheduled, the administrative assistant is scheduled to end October 22nd. And then the permit tech is actually a position we're bringing to the BOCC in our 2022 budget approval process as a regular ongoing position. So we're considering those a little bit differently, but the darker red positions are the current term limited COVID specific positions that we have asked and received approval from the BOCC to extend through March of 2022. So those are the positions that will be extended. And then if we can go to the next slide, please. The green boxes that you'll see there in the middle are the 6 positions that we are requesting as 18-month positions that go through June of 2024. We've really been thinking about what the needs are of our community and of our team, and thinking about restructuring the previous 15 term limited COVID specific positions that we've had to bring it into these 6 positions that we'd like to maintain through June of 2024. So the green boxes are the new asks, the red boxes are the ones that we have asked for extensions on, and we may have some people from those red boxes applying for the green positions, and at that point we would not backfill the red term limited positions. So this, we wouldn't necessarily have this many people at any one time, but wanted to present all of those positions at once so you can see them all. And then if we go to the next slide, you'll see the org structure that we're hoping to have starting April 1st of next year. So we have all of the COVID positions in this one part of our department, really serving as a program, as you've seen with like our mental health work or other parts of public health, as a separate group, rather than having all of our staff responding to COVID at the same time, which of course we will be available and supporting the COVID work as needed, but really centralizing all of the COVID specific tasks within these positions. Moving forward. Any questions around where we are and where we're hoping to go over the next few months here?
I'm looking for hands up if there's a question. The comment I would just add to that is that when these requests come to the BOCC, we do take them very seriously, one from a budget perspective as well as from, with needs. And we usually have a fairly robust conversation. It comes in a couple of readings from our budget director, and we have the opportunity to drill down and ask the hard questions, and then also to find out, do we have the money to cover this in our budget? And thankfully, we do. We're in a really great position fiscally, and we're able to take this on for the foreseeable future. But still, we always ask the questions, and we're certainly trying to be as nimble and as efficient as we can. And I want to thank the public health staff for indulging us with all the questions we ask when they come before us with these requests. So thanks to Zuho. You want to go ahead? What's next?
Thanks, Greg. Yeah, no worries there. And some of you might notice that communications is missing from this, and we want you to know that even though it's not sitting within public health, we are continuing to planning to continue to work very collaboratively with the communications staff who will be working under Kara and Phyllis, as some of them have been already, but we decided to separate that out a little bit. And then this last position, the community engagement and communications coordinator, would serve as a liaison to that team as well. So I just want to make sure that everyone's aware that our communication channels will continue. We know how valuable that is.
Thank you for bringing that up, because that has been really important. I think for me in particular, communication have always been, it's easy to neglect that when you're in the fog of war, so to speak, but it's so essential. And I think our conversations today are going to reflect that, because our communication strategy and practice going forward as we approach winter is going to require us to engage the community beginning now, so they all know where we're going and where we think we may be going with this winter. So looking forward to that conversation. Thanks.
Thanks, Greg. And I just wanted to clarify one thing. So my friendly colleagues have told me that I've said 2020 and 2024 at different times. So I just want to, it's actually 2023. So the positions and the grant funding that we have is for a year and a half, starting at the beginning of 2022, going into June of 2023. So thank you, colleagues who have slacked me on that. So apologies. All right, next I'll turn it back to you, Greg, and then we'll have our mental health presentation.
Great. Yeah. So up next, a mental health presentation, and we've got Chelsea Carnoli and Jenny Lyons coming in to help us with that. It's an update on the continuum and the PACT program. And it's actually been quite a while since we've talked about this. And we were all very enthusiastic, engaged in this at the Board of Health before the pandemic. So it's good to pick this up again. Are they here?
We are.
Okay.
So this is Jenny Lyons. I have the first part of this presentation. I am the mental health program administrator for Pitkin County Public Health, in charge of the PACT program. So we'll have an overview of PACT in a few minutes. But first, we're going to kick off with a bit of an overview of what's happening with the state opioid settlement. So we can go to the next slide, please. And so this, we pulled this from presentations that the Attorney General's office has been making about this settlement. And these are the core principles that they wish to honor when thinking about this opioid response joint framework, which will include the settlement funds that will be distributed. So they have been working on, the Attorney General has been working with numerous stakeholders on a settlement fund, settlement amount for some time. We can go to the next slide, which will have more detail on that. And so the proceeds include about a total of $385 million, which will come in over 18 years. And this slide provides some of the sources of that funding. And so this is specific to the state of Colorado. And then the chart on the other side is showing how those funds will be distributed over the years. The largest amount of the funds will go to these regional groups, of which Pitkin County is a part. And so I'll have more detail on that soon, but I think it's worth calling to mind that 60% of the funding is going to go to the regions, at least somewhat based on population of those regions. But there will be some state administered funds for infrastructure or for other places around the state that have particular difficulties. And there will be a certain amount that goes to local governments. Local governments can determine on their own if, for example, they feel they don't have a good program or want to start up a way of spending that funding, they can add that to their regional pot if that's something they wish to do. So that is one thing to be aware of. And again, I mentioned that this is coming in over 18 years. Most of the funding will be in those first 10 years, tapering off significantly in the last 8. We can go to the next slide, which shows our region. So we are in Region 5, along with Garfield, Summit, Eagle, and Lake counties. And so this shows the 19 regions around the state. So we are with other mountain communities that will probably have some similar challenges to what we have. But we're at in different places as far as responding to this. For example, Eagle has kind of a more robust mental health system because they have Vail Valley Behavioral Health that is funded in part, I believe, by their foundation. We can go to the next slide, which talks about the workshop that the Attorney General's office convened on August 17th. We had great representation from Pitkin County, including Commissioner Child, Nan Sundin, our Director of Human Services, and myself all attended in person, and Chelsea Cronoli, our mental health analyst, from whom you will hear next, attended virtually. And at that meeting, kind of the biggest, I would say, decision that was made, which may still need to be ratified by all the counties, is that the Attorney General's office had proposed a couple of different governance structures for the regional committees. And one involved having multiple voting members from each county, and then like a representative from Human Services, for example, from all 5 counties, and that each of those folks would be voting members. The commissioners and other representatives that were present felt that it would be most expeditious to go with a one vote per county model, which some of the other regions are also leaning toward. So major next steps with the opioids settlement will be to have our county commissioners sign the MOU with the state, as well as the settlement documents. The more a certain percentage of counties, I believe it's about 70%, if 70% of municipalities agree to participate in this settlement, the state will get more money. So that's something that the Attorney General's office is working on. That will be sent out to the commissioners once it's ready to go. They expect it fairly soon, but I don't have a clear timetable on that.
Could we ask, if there are any questions on this? If anybody has a question, yell at me or raise your hand. I'll be looking through our, just to see if anybody.
Comment?
Dr. Kurt?
Am I unmuted?
You are. Yep, go ahead.
As a board certified medical toxicologist and a founder of the North Texas Poison Center on the model of the Rocky Mountain Poison Center in Denver, I'd like to comment on this as the opioid situation has involved me as a kind of a part of my lifetime. I'm on the Colorado Consortium for Prescription Drug Abuse Prevention on the harm reduction for the state. But I've not really taken part in anything locally because we haven't had anything locally to really implement this. I'd like to point out a critical area. We have a detox program in the county, and I'd like to see that detox program involved in a kind of an opioid umbrella of the public health services. At the present time, that's funded, but it is not specifically underneath the umbrella of the Pitkin County Department of Health. So I strongly suggest that we do that and implement further interactions also with the pharmacy at Aspen Valley Hospital, which deals with opioids as well in the treatment of emergency patients and inpatients with the medication called bup or buprenorphine, which is used as a kind of a methadone to keep people off of street drugs. So that's my comment. I'd like to see this further implemented in Pitkin County, to see the detox program that currently exists under the umbrella of Pitkin County and further expanded. Thank you.
Dr. Kurt, thank you for that comment. It's noted, and we'll get Jordana and Suzuho and team, Jenny and Carnell and Chelsea to contemplate that, and we'll get some feedback on that. It's a great suggestion, and thank you for your insight. I did have a question just regarding the region we're in. And maybe it's fine. I'm thinking a lot about redistricting lately and just looking at Garfield County. I think most of the opioid problems, as I understand, are farther to the west in Western Garfield and Mesa counties, which have a much larger opioid problem than we have here in the higher mountains. And I'm wondering if there's any feedback or I'm sorry, Steve Child, if he's here, Steve, if you're around, I'd like to get you to chime in, but I'd love to just hear impressions from Chelsea or Jenny or Nan, if Nan's on, about how that meeting's going, and do you anticipate any bumps in the road? Because this will come to the commissioners to ratify this, as I think you just said. Any comments there? If there's nothing there now, we can keep moving, but I'm just thinking I'll want to hear, I'm sure the BOCC will want to hear about that.
Sure.
Before the next.
I don't feel like we've delved into that enough to comment on whether I have a sense of what all is different or might be different in Garfield County. And I think Chelsea will present a little bit more on, she has more of the numbers on what our opioid problem might encompass. What I do know is that we do have, to Dr. Kurt's comment, we do have fairly high prescribing rates for both opioids and benzodiazepines here in Pitkin County. That is something that's tracked at the county level in some state databases. So I do think that there could be additional collaborations and partnerships. I would also say that it's worth all of us being aware that through St. Mary's, there is a SAMHSA grant that has created some work groups in Western Colorado on the opioid issue. And our local Roaring Fork Valley work group is led by Jared Rollins at Mid-Valley Family Practice. Chelsea and I both participate in that, representing Pitkin County. And as well, there are a lot of other great folks. And that's a Roaring Fork group. So we go down into those areas of Garfield County. And there are some different services available there. One other thing I'll note is that while Pitkin County does have a social detox, which is provided by Recovery Resources, Garfield County does not. And there is a group that is trying to stand one up in Garfield.
Great, thank you for that. So it could be that I stand corrected in my assumptions, but about the spread or the distribution of the opioid problem, so to speak, among our counties. So anything you want to add to that, Chelsea, or just push on through, but correct me. I'm happy to be corrected. Thanks.
Yeah, I wouldn't say that necessarily that I have a handle on. Yes, we have an equal problem to other places. Those are just some of the indicators that I'm aware of, for which we have hard data.
It is something that's so early in trying to understand how we can be really collaborative with those Western counties that we so often traffic through, whether that's people living in Garfield and working in Pitkin or being educated in Pitkin, however that may look. There is a new harm reduction organization that's done a fabulous job, both interacting with users directly as well as connecting with state funding sources, is active in those groups that Jenny had discussed. That is called High Rockies Harm Reduction. The founder is Maggie Seldine. In discussion with her earlier this week, she did provide some narrative where we are lacking those hard numbers locally. Maggie mentioned that we do see there's a common thread of fentanyl being laced in really any common drug use. So she mentioned in Aspen, we see a lot of cocaine usage. And yes, in the Western Garfield area, there is more methamphetamine, both of which there's a high risk of fentanyl being involved, which is leading to a lot of deaths statewide and locally as well.
I'm holding up a box of Narcan or naloxone nasal spray, which can be used. You can have a kind of a distribution and education program with this in critical areas, such as libraries in Denver have a high rate of using this. Librarians are people who come in, from the street and collapse and are resuscitated.
Great, thank you. And I know we've heard about the distribution of Noxalone ubiquitously. I'm not sure how that's going or where it's going to end up, but if this is the time to add something on that, that's great.
Sure. In December of last year, Dr. Levin provided Pickens County Public Health with standing orders for naloxone, and we signed up to be part of the state bulk Narcan fund. So we are getting those nasal sprays from the state at no charge right now. Right now, most of our supply has gone to one training that was held at the Safe Outdoor Space a few weeks ago, and to Snowmass Village Police, who have recently decided to begin training their officers in carrying naloxone. So we have more on order, and when we have that, we can also, and we're also working on a distribution policy for public health. So all of that is part of our strategy.
Great, thank you. I'm anticipating somewhere down the road, maybe Board of Health members and others could get involved in a training in that as well, just to understand it more.
I just would like to add my 2 cents on this too. Actually, what I do at the VA on a national level is I am an ex-waiver provider, and I help get veterans off of opioids. We have at the Grand Junction VA for our Pitkin County residents, as well as the whole Valley, both detox for alcohol and opioids. We have a very robust naloxone distribution plan. And part of what we do is a lot of education to our other members of like the VA, but we're kind of this isolated network. So obtaining this X waiver, which when I did it, I had to do a number of training, has become much easier for primary care doctors. I really feel like it probably is worth Pitkin County Health's time to reach out to these primary care doctors and really get as many people X waivered as we possibly can, because prescribing Suboxone is very easy. It's very safe. It's much safer than all the other opioids that are prescribed regularly for the number of pain complaints they're prescribed for. And there recently just has been a lot of these barriers that have been reduced. So I think just again, education to the medical community around this and really encouragement, I highly recommend.
Thanks, Krista. And Dr. Kurt, did you have another question, or can we keep moving?
No, I think as Krista described, the X-rated physicians can prescribe buprenorphine, and locating where those are in Pitkin County and augmenting them would be great as well.
Great.
I just
Thank
wanted
you.
to comment as well that there is a standing order at all of the pharmacies in the county for naloxone, and that the emergency department at Aspen Valley Hospital is working actively with the state to be able to dispense naloxone to appropriate patients on site there. And also the ED doctors are working on being prescribers of Suboxone from the ED and starting it there in a critical moment to be able to refer people out for it as well. So a lot of work being done.
Great. Thank you. Jenny, any more on this from you or Chelsea?
I don't have anything else. I'm ready to move on to PACT unless Chelsea has anything else.
Okay, we're going to move on to the PACT program. We're going to keep it on schedule here. Thank you.
All right. So PACT stands for Pitkin Area Co-Responder Team, which pairs a mental health clinician with local law enforcement to respond to calls that have a behavioral health or substance use component as determined by the officer. We have 2 ways that we respond. Our clinician often offices at the Aspen Police Department, and we'll do a primary response going to the scene of a call or a follow-up with the officer. And then we also do what's called secondary response with the Pitkin County Sheriff's Office and Snowmass Village Police, where often the officer will arrive on scene first, or if perhaps they triage from the way the call comes into dispatch, and the clinician will meet them on scene. We also have a case manager and a peer specialist who provide follow-up, and they really work on reducing barriers to treatment for folks, including stigma. Our peer specialist is kind of our superhero in that sense, someone with lived experience themselves who can come alongside people and share that and help them to walk toward finding a better future. I'll run through the partners. Pitkin County Public Health holds the grants. MindSprings is our behavioral health contractor, and I've mentioned the 3 law enforcement agencies that are involved. We have 2 grants that are completely funding this program at this time. The original one is from the Office of Behavioral Health through their co-responder grant program, which started in, I believe, 2017. So we have been a recipient of that since that time. And that program is a reason that there are a good number of correspondent programs around the state of Colorado. We were one of the first rural programs in Colorado. And then in July of 2020, we were awarded a harm reduction grant, which is part of the opioid overdose prevention work done by CDPHE. So that is essentially doubling the size of our PACT program, that second grant. The data that we'll be going through has been largely tracked for the OBH grant, as well as we're supplanting some dispatch data with that. The purposes of PACT, when it was created, are to decriminalize mental illness, divert calls and reduce the police involvement in these calls, reducing incarcerations for low-level offenders with mental illness, decreasing emergency room visits for mental health care, and reducing repeat calls for service for individuals that need community-based services. So the data that we will be going through in the next few slides is for the second quarter of 2021, which is our most recent kind of combined data report. There are some longer contexts when it's available. A couple of challenges that I'll just mention to our data collection and analysis include that the state has changed their requirements several times since the inception of this grant. So we're not always able to compare apples to apples over time because we've been asked to do things a little bit differently. We're also asking more questions as we get further into the program and refining how we collect data. The new grant and the growth of the program have also contributed to some of this difficulty and sometimes turnover in our position. Next slide. So this is the beginning of our data. Looking at, that is not the next slide that I have. Thank you. This is our call profile, the behavioral health related calls that we have been tracking, as well as the total number of dispatch calls. So that total number of dispatch calls is coming directly from the law enforcement agencies. They report that to us every month. And then the behavioral health related calls we are tracking in concert with dispatch. Those are still identified by people. So either those are calls that PACT actually goes on the scene, or they are calls that PACT is requested to do follow-up. So it's certainly possible that we'll find that there are more calls out there that we are not necessarily capturing. But we've been consistently doing this for some time, and we believe that we'll keep refining that process, but we're doing kind of the best we can in the systems that we're working in.
Hey, Jenny, just
sure.
just wondering, these trend lines are kind of interesting. And I'm just wondering if this is trending the way it is anywhere else. Is this what you'd anticipate?
Like from across the state?
Across the state or elsewhere, because I keep hearing about PACT programs coming in and getting really great public response. And I'm just wondering if you have data that kind of verifies what we're seeing here. I think there's a pandemic element to this. And then, as you say, maybe as the program matures, it gets a better call volume. I'm just trying to understand this a little better.
Correct. So I would say there was a big drop in calls because of the pandemic, likely because of the pandemic, in those early months of 2020, which is shown here. So this is one of the places where we have that longer context to look at. And then we saw a spike in the summer, which is consistent with crisis calls do also tend to increase in the summer. And then kind of drop off and level down somewhat, our overall police calls. I think that some of looking at this has to do with, if you're looking at the total number of dispatch calls, that's really impacted by how many people are in town. So that's going to go up and down somewhat with our seasons. I would say that PACT had increasing calls in the summer in both 2020 and 2021. I don't know if that will continue to going forward, but we did see higher levels of calls in the summer. I think partly because our theory would be that people are out and about more often, interacting with other people more, so the police end up getting called. And I have the state very recently released their overall co-responder report for the last year. And I have not had the chance to kind of overlay this with what they're finding. So I will try to do that for the next.
Great. Well, thank you for that. Thanks for drilling down a bit. I think we've got
Of
about
course.
5 more minutes in this presentation just to keep us on track.
Okay, I will kind of put the gas on. That bottom statistic is really showing the commitment of our law enforcement to providing training for their deputies and officers. Okay, next slide. This is looking at our total encounters. This is really, really similar to what we saw in the first quarter of 2021. So this is showing really consistent. I will note that our case manager is fairly new. She started with us in April of 2021. So there was not a whole lot of time that she was in the field. Next slide. This is basic demographics. I will say, commenting on state, what the rest of the state is seeing, we probably see a little bit higher percentage of folks over the age of 65 who are involved in our calls compared with the rest of the state and what they want. And next slide. So this is a little bit about our encounter profile days of the week. We are definitely finding that the trend is similar to what we saw in 2020. Those are overlaid on the right-hand side. And so far it is showing that we have the right days and times for our correspondents to be on shift, but we will continue analyzing this. We can glance at the next slide. So that's looking at, we are actually seeing a peak of those calls during the day, which is when our corresponders are on. They're usually on from 7:30 to 5:30. We can go to the next slide. This shows our breakdown of which agencies we are involved with the most. So that is actually shifting a little bit. In 2020 and the first quarter, we saw an even higher percentage that were coming from APD, and almost even breakdown between Benton County Sheriff and Snowmass for the others. And we can go to the next slide. We are almost to the end of these. This talks a little bit about the type of responses that we're doing. I'll just summarize that most of the time we are spending on follow-up, working to get people connected and avoid future crises. Next slide. We are showing that nearly 80% of our calls are being resolved on scene. The emergency department refers to the emergency room at ABH, and withdrawal management is recovery resources. And the final slide here talks about updates. Our second co-responder clinician just started last week. She is in field training, and we expect her to be on her own in the field in 4 to 6 weeks. APD is also adding a second human services officer. And once those 2 folks are fully onboarded, PAC expects to go to a 7-day schedule. And we really want to watch the data closely to see what happens with that. And the future also involves reaching out to more community partners and finding ways that we can be in touch with people before they're reaching a level of crisis where law enforcement has to be involved. And I will hand it off to Chelsea.
Great, thank you. Just yell at me if you have any questions. Anybody? Just quick observation, just that I'm struck by the numbers from Snowmass Village, we can drill down on that another time, but that's my takeaway. It was a little bit of a surprise. Like just population density, maybe that's it. It's where the tourist beds are. Okay, Chelsea.
Thank you, Commissioner Gray. Thank you, board. So as many of you are aware, if not all, there is a mental health crisis that has been in place for quite some time. Locally, we decided to respond to that following the 2017 regional health assessment, which did identify mental health as a top concern. Following that discovery, a group of Pitkin County leaders formed a group to identify gaps of mental health care and accessibility for our area. Those results showed room for improvement in some different phases and areas, including promotion, prevention, treatment, aftercare, particularly in accessibility seen by community members as in barriers getting to doctors' offices, as well as stigma. In an effort to fill these gaps, Aspen Valley Hospital, the school district, the city, as well as Pitkin County, committed to funding the Vital Mental Health Services contract to aid in the creation of some community-based services where mental health service providers can travel directly to clients within the community, as well as school-based therapists meeting students and families in neutral, accessible areas such as schools. Additionally, there is a subcontract for integrated care behavioral health workers where they're able to serve primary care patients right in a doctor's office. Next slide, please. So this Vital Mental Health Services contract has grown into a multifaceted system of meeting those high-need, high-risk clients in the field, which is alleviating the previously identified barrier of accessibility. MindSprings Health originally won and still holds this contract. That subcontract for integrated care is held by Mountain Family Health's Basalt Clinic. At this time, the fund pays for 2 full-time school-based therapists who are in the Aspen School District, 1 full-time community-based therapist, and 1 full-time community-based case manager. That subcontract with Mountain Family pays for 2 full-time therapeutic providers in the clinic and 2 full-time care coordination nurses. So far, we have 2020 information that shows 211 youth and adults were served in those community-based programs. And the purpose and the assistance of that goes from diversion of care, from higher levels of intervention, like in Aspen Valley Hospital or in the jail. They also assist with the intervention and the treatment and aftercare phases previously identified. They do this by creating that support system of natural supports for those individuals who generally are more isolated because of those barriers to access of care. They also provide ongoing treatment and case management for those high-level need patients, which includes mental health and mental illness, as well as substance use challenges. Oh, I'm sorry. Next slide. And I moved a little too quickly. Next slide again, if there are no more questions. Within that integrated care subcontract, we saw 1,008 visits between January 1st of 2021 and May 1st of 2021. So that clinic is providing that integrated care, which helps folks be seen all with their medical, dental, vision, and behavioral health needs all under that Mountain Family roof. They also assist with Medicaid enrollment as well as any other financial needs, and they do help with that care coordination. That clinic serves indigent, low-income, Medicaid, uninsured patients. They also have bilingual and bicultural staff members. This graph, which may be a bit hard to see, identifies some of those different payer sources and breaks down what that community or what that clinic is able to serve. 26.5% of those patients are uninsured. Another 41.3 have Medicaid. 21 use private insurance. 7.3 are on Medicaid. 3.1 are on CHIP, and 0.5 are other. Next slide, please. For our school-based therapists, last school year, which is that 2020 start in the fall, 2021 in the spring, keeping in mind this does include the off and on of COVID, there were 117 youth seen, which includes their families. And those therapists are providing on-site student and family therapy and support. This, again, improves access and participation in therapeutic services for the youth and family, where previously identified access to care was a concern and a difficulty. Additionally, there is an opportunity for coordination of care within the school, which includes the Aspen Family Connections Resource Center, Department of Human Services, and of course, school staff when necessary. Next slide, please. Moving forward, we are, of course, maintaining that vital mental health services contract. Right now, we do have some open positions. We're needing to fill that case manager community-based position. We are in the final stages of hiring for an additional, which would be our second full-time school-based therapist. Also, we are reconvening where we had left off before COVID with some strategic planning. What that will include moving forward is a community mental health needs assessment, which will roll out this fall. We are also partnering with stakeholders and community organizations to better see how we can assess and implement that community needs assessment, as well as follow through with gap analysis and trying to better understand how we can fill in the gaps that we learn. We are continuing to lead and attend any meetings that will help that voice and help that vision move forward. And we are wanting to, throughout every step of this process, include equity and connection throughout the function of all of our efforts. Additionally, there is some money coming down from the American Rescue Plan Act, which is a federal funding source and is distributing to states, which Colorado is getting roughly $94 million for. And with this money, the state is creating a behavioral health task force to better assist individual counties and communities throughout the state in implementing some of the structures that we are working toward at this time. We don't have a lot of details on that funding source quite yet, but we are working toward using it and communicating with the state in the best way possible. Are there
Great.
any questions?
That's it. Yeah, any questions? I'm going to try to keep us moving here. I want to get us back on schedule.
Greg?
Yes, go ahead.
Yeah, it's Ann. Thanks. Just real quick about the results. I saw the number 1,008 visits, excuse me, and 117 student not interventions, but contacts. Do you have data, Chelsea, do you have data from previous years? And I know the last couple of years have been a little bit odd, but it might be good to see what happened in the 1920 school year, or you had the data from January 21 to May 21, what happened previous to that, just for comparison. That, and also I was part of that group in 2017 that came up with this proposal. I would be very interested in going back and looking at what we found were the gaps, what we found were the needs, and how we have addressed those needs, or how those needs and gaps have maybe changed since 2017. At some point, just again, doing a reanalysis of the findings that we came up with that brought us to where we are. Again, all kind of results motivated.
Thanks, Ann.
I have a suggestion.
Go ahead, Dr. Hurt.
I suggest a big information source could be Steve Ayers, our county coroner, because he can tell us about mental health issues related to time of death, as well as drugs of abuse. That could be very interesting for us to see, you know, the frequency and the type.
Thank you. Thank you for that. Okay, Chelsea, I'm going to try to keep us moving. Anything else here, or are we ready to transition over to, we've got looks like we have a guest here to talk about. You ready for that? Okay, we're going to talk now, transitioning here to the flavor ban and TRL policies on tobacco-free kids program. And I think Jody's here. I do see a question from Tori first, though. Go ahead, Tori.
Yeah, just a comment here, Greg. I just want to compliment the county and the county public health team on the presentation that we just got. You know, the formation of the PACT over the last couple of years, bringing Chelsea onto this team, work Jenny's doing. I mean, really great work. A long time maybe overdue for our community, but I see what was just presented to us as tremendous work in our community. And I just want to say thank you to everybody that's working on that, because it's really an act that gives a lot of hope to a lot of us. We recognize that we have these issues in our community, and attacking it as strongly as we are, putting the energy and the resources and the talented individuals that we have is just, it's really great to see. And I just wanted to just take one moment and just say my appreciation on behalf of the city of Aspen as well. I mean, it's just really great to see.
Thank you, Tori, and I apologize. I'm in such a rush. I passed over that, but it's actually even more meaningful to hear it coming from the mayor of Aspen. So thank you for that. Anyone else before we shift? I don't see it, but if you just speak out. So Jody's here. I see you on. Welcome, Jody. Thanks for joining our meeting. And please, we're going to try to move fairly quickly. So we're just going to give you the floor. Thanks.
Sounds good, Commissioner. And I'm going to do my best to keep you on schedule. So I'll abbreviate some of my commentary to try to make this work for you, given your agenda today. Larissa, thank you for coordinating. For those of you who don't know me, my name is Jody Radke. I am the Regional Director with the Campaign for Tobacco-Free Kids, and I have worked and continue to work extensively on tobacco control policies for, I think, nearly the last 20 years here in state and across multiple states. So I'm excited to partner with you on any future policies that you are interested in working on. Just to give context for this discussion today, I presented, some of you might remember, Commissioner, you likely do, before COVID, Karen Koneman with Pitkin County Department of Health and I both presented on multiple tobacco control policies and considerations for Pitkin County. And then COVID happened and kind of put a pause on some of that discussion. So this is really an intent to revisit where we left off in that discussion and to present to you what has happened between then and now, and see if there is any interest in some alternative policies that were discussed before. And before I jump into that first slide, that website at the bottom, I just wanted to include that. I'm going to talk a little bit about Denver's introduction, which is coming up, and that's part of the context of what's happening across the state. But that's a location that you can get a sense of what's current and what we're working on, and the context for this issue overall. Larissa, if you can go to the next slide. I don't think I have to remind any of you, but I think it's always important to level set. Smoking is the #1 cause of preventable death and disease in the US and here in our state. It kills 480,000 people annually, which is more than the various incidents combined that you see here in the sentence. And the important thing I think to remember here is that the average age of initiation with tobacco is 13. We know that most of our kids who become lifelong users start before the age of 18, 80%, and then 95% before the age of 21. So that makes accessibility to the product really important, and understanding what the catalyst for use is amongst our kids. And we know that that choice has consequences. 3 out of 4 of our kids become lifetime users that are experimenting, and that results in lower income earning potential and shorter lifespan. So a critical public health issue. Next slide. So why should we care? I think a lot of us have gotten lost in the pandemic, and for valid reasons. But I think a lot of us have forgotten also that prior to the pandemic being declared, that the US Surgeon General declared an epidemic amongst our kids and youth vaping. So we quickly went from counting lung injury illness cases with our kids to counting pandemic deaths, both of which are highly unfortunate. And even more unfortunate is that the epidemic of tobacco use has not ended. In fact, it's continued. And so this is one case of many across the country. There are thousands, including here in state. This is one of the more egregious ones, where one of our physicians at Henry Ford Hospital in Michigan performed a double lung transplant surgery in 2019 on a 17-year-old. And that really is the gravity of what we're talking about here. And this particular 17-year-old has recovered, thankfully, and has since become an advocate to really influence his peers and other youth across the country to not go down the path that he went down that resulted in this. But this is the critical underscore of what we're really contending with. Next slide. And I don't have to also share the complexities of COVID, but with all of you, because I know you're well versed in this, but we are finding in studies that are being done now that vaping and smoking exacerbate the symptoms of COVID and also increase risk for our teens and young adults who are experimenting with both. So even more of an exclamation point in terms of our concern around their use. Next slide. I'm going to show two graphs here, and I won't ask ages of anyone that's participating on today's Zoom. But that left graph, if you were a child of the 70s or if you were an adult in the 70s, these numbers may sound or look familiar to you. The top line are 12th graders, the middle line is 10th graders, and that bottom one are 8th. And that number goes back about for a 30-year time span. And at the height or peak of that left slide, you'll see a number close to 30%. And that was the history of cigarette use with our kids back in the 70s. And you can see how quickly over time we were successful in achieving a declination of use. And we're hovering around 4 to 5%, depending on what area of the country you're looking at. Here in Colorado, it's around 5% of our youth smoke combustible cigarettes. So we've made incredible progress. That graph on the right also presents smoking declinations, that blue line, but the inverse relationship to that is that yellow line where it shows vaping use over time. And that number is hovering nationwide and here in the state where we've made some progress, we're actually less than that now, but it's hovering around 30%. So the same rates we used to see in the 70s with combustible cigarettes, we're now seeing with vaping products amongst our kids. And the good news is that, or the bad news is that we're repeating history. The good news is we know exactly how to reverse the trend. And we do that in partnership with elected officials and boards of health such as yourself. Next slide. The catalyst for use, we know what is contributing to the epidemic we're seeing, and it's flavored tobacco products unequivocally. And what you see here is a slide of a sample of items that kids are seeing every day and working left to right. These are actual products that you can find on the market. The slushy, which looks very much like a Slurpee, includes e-cigarette or vaping juice or liquid that's contained inside of that container. And then you work to your right and you see smokeless tobacco flavored cigars, really appealing price points. And then of course, menthol cigarettes, which is the only legal permissible flavor of cigarettes that's on the market today. So we know flavored tobacco is what's really the catalyst for what we're seeing in the rates today. Next slide. Giving you a sense regionally, I wanted to, because there's been so much progress that's been done, not only in Pitkin County, but neighboring counties that's really led the state and served as a compass in this area. But I wanted to give you a sense of where you're at currently. So looking region 12, which includes the counties that are listed here, including Pitkin. If you recall, it was just a few short years ago that the western area of the state was leading the nation in use rates amongst our kids. And those numbers have since come down because of the incredible progress and success and policy change that have happened as a result of all of you who are on this call. But vaping use currently hovers in region 12 around 29%, cigarette use around 9%. And then we look at, when we ask kids, how easy do you feel it is to access these products? You see the corresponding numbers, 65 and 53%. So pretty high in terms of kids that feel these products are easy to get if they wanted to have access to them. Next slide. It's important to understand how kids are getting these products. The tobacco and vaping industry will often claim that kids are accessing these products online. But when we reference and look at the Healthy Kids Colorado survey and ask kids how they're accessing these products for both cigarettes and vaping products, we know that they're getting them from adults that are of legal age and going into purchase for them. So sometimes that's a kid throwing an extra $5 or $10 to an adult going in to help offset the cost of their own product, and the adult's willing to do that for them, or someone that they know is purchasing it and giving it to them. But these are legal age adults that are going in to purchase the product and getting it for them. And you see the corresponding numbers here. And the important thing to remember related to this also is that when we talk about flavored tobacco is primarily being used by kids. When we look at adult use rates across the state, about 5% of our adults are vaping, even fewer of those use flavored. about 3.5% for smokeless tobacco, and then about 14.5% of our adults are using combustible traditional cigarettes. And even fewer of those are using flavored. And again, the only flavor remaining on the market is menthol. So the percentages of adults that are using flavored products is really low, although the industry likes to inflate those numbers. So we're really talking about kids and use amongst kids. Next slide. When we talk about flavors, I think all of you are well aware, dating back historically and to current day, you see common themes amongst why flavored tobacco products are on the market and why they exist. And you see youth, you see teenagers here, and references to honey and different flavors and candy. We know exactly why, you know, flavors exist in tobacco products, and it's to make these products easier to use so that they can introduce kids to create lifetime users and to ensure that they have a pipeline for generations to come. Next slide. As I mentioned, I just wanted to include a couple stats in terms of youth use. Over 80% of our kids are reporting to us that they would never use combustible cigarettes, but that they are trying vaping products because they are flavored. And over 70% are reporting that they continue their use because they are flavored. Next slide. The most alarming part of this trend that we're seeing that I wanted to share with you, data from CDC last year, and consistent with what we're seeing in Healthy Kids Colorado survey, is this trend line of kids that are experimenting or trying e-cigarettes or vaping products for the first time and maybe not using them. We're seeing that change over time. And here you see that an increase over time of kids that are using these products 20 days or more per month. And in the Healthy Kids Colorado survey, we asked kids about their intolerability or intolerable cravings and inability to focus over periods of time without having to leave to get a hit from a vaping product. And so this is consistent with what we're seeing here in state, and you see the rise over time. So these are kids that are becoming addicted very quickly to these products, and that number is currently hovering close to 40%. And that's something we are committed to reversing. Next slide. You know, we often hear in this work and talking to cities and counties around interest in these policy changes. And one thing we hear often is, why don't we wait for the federal level to make this change? And, you know, the reason that we are in the place that we are, and the reason the US Surgeon General declared youth vaping in particular an epidemic, is because the feds really failed to act. They allowed these products to enter the market illegally and remain on the market, which created a market of over 1 million products that currently exist across the country with very easy access to them. So inaction at the federal level is what resulted in that problem. And the state could have acted quickly to resolve that issue and to protect Colorado's kids, but that didn't happen either, and it still hasn't happened. And when the state fails to act, and when we see inaction at the federal level, we really see the cities and counties as a safety net to protect the health and welfare of our kids. And this epidemic hasn't gone away. Our use rates have come down some in the western area of the state because of the proactive work that's been done by elected officials. But there's more progress to be made, and we're really trying to have these conversations with cities and counties where there's still gaps. I think next to last slide. So I just want to update you on where and what has happened since the last time I was in Pitkin County with Karen Koneman, and the successes we've had in Colorado, which have really been incredible. Tobacco retail licensure is a critical part of this conversation to ensure that we hold our retailers accountable who are selling to our kids, but then also to know who is selling to our kids, and to make sure we have an accurate database of that so we can track that. And then when we look at tobacco retail licensure in the state of Colorado, we have 32 cities and counties currently that have ordinances in place. And that does not include Pitkin County, but it does include your municipalities. So that's one area I think that we would have a recommendation or suggestion if there is interest to do so. Minimum legal sales age, 38 cities and counties. That does include Pitkin County, which is really great. And that's really aligning the sales age with what policy exists at the state level. And then of course, the federal change under the Trump administration, which mandated minimum legal sales age to 21 across the country. Flavor restrictions is, again, one that got put on pause because of COVID. That's a large reason in terms of early conversations we had and now revisiting where we left off. We have 6 cities, the most recent being Edgewater, that have passed flavor restrictions across the state. Our most current one that is preparing for introduction in 3 weeks is Denver. That's why I included that flavorskiddenver.org, so you can get a sense of what that work looks like. But that introduction is happening October 6th, and that will be the city and county of Denver. So hopefully we'll have 7 next time I do the slide deck elsewhere. And that doesn't include Pitkin County, but flavor restrictions do exist in Aspen, as you likely know, Snowmass Village and Carbondale, Glenwood Springs, and a number of the communities in the area. So we are much appreciative of the elected officials for your leadership in the space. And then Price, we have 15 cities and counties, and that does include Pitkin County. And again, a number of municipalities across the western area of the state. So we're really grateful for the progress that's been made there. And then last slide, and then I'll just pause for questions. Wanted to share with you that we are building this list across the state. This doesn't include all of our supportive agencies and organizations and public health partners, but we have now surpassed, and you may have seen this in the news because it's been on a few different places in print and on TV. We now have over 100 organizations in state that are supporting this policy change and advocating for cities and counties to partner on this policy to move forward. I'll pause there, and I just want to thank you for your time and including me on your agenda today. This is a really important public health policy that's a protective mechanism for our kids in terms of a lifetime use that eventually will kill them. We know this product, when used as intended, is the only product that will kill them. So we appreciate your time, and I'll just pause there if there are any questions, Commissioner.
Great. Thank you, Jody. That was impressive. That was a huge data download. And I don't know if you took a breath, but you did it smashingly. That was wonderful.
Trying to keep you on time, Commissioner.
Yeah, thank you. You
welcome.
helped out a lot there. And of course, the big question mark, and I'm trying to remember back, where were we and why regarding retail licensure for Pitkin and flavor restrictions. And I think our public health staff is probably going to want to get back to us about that. I do recall testifying down in Denver at the Capitol with a former public health board member, our board of health member, Brent Miller and Karen back in the day before all the COVID, before BC, before COVID. Yeah. And so it'll be interesting to hear back from this. Does anyone else have a question? If I don't see it, please chime in. I see Jordana's back also. There's Dr. Kurt.
Are we using our $2 a pack cigarette tax to educate and people regarding tobacco and vaping dangers?
The question was, how are we using a $2 tax? And that's probably a question that'll go to Jordana looks like Jordana's going to on deck for that. Thanks.
The money that we get comes back to help fund the public health department in general, but specifically the funding that's used for our tobacco coordinator position. 75% of that comes from state funding, and the rest Pitkin County we pay for with our Pitkin County funds.
Great. Thank you, Jordana. If there aren't any other questions, Tori's got one. Go ahead, Tori.
What is the online availability of these products?
I'm gonna have a ringing. Okay. The online availability is pretty limited. It's changed. The landscape for that has changed considerably. There's been federal policy that has passed this last year. I apologize for the ringing in the background. Federal policy that has added vaping products to the restrictions for delivery systems. So the US Postal Service, FedEx, and UPS can no longer deliver these products as they did before. So the accessibility point for kids is decreased considerably. And so we're seeing less kids trying to access them via the internet or online purchasing, and more of this finding an adult to purchase for them. And as you saw, the numbers for Region 12 are around 4% for both cigarettes and vaping products, and that is largely reflective of the federal change.
Thank you.
Mhm.
Yeah, that's impressive. Just to make sure there's nobody else. This is great. Oh, Ann, is your hand still up from before, Ann? Or is there, I didn't look like a
All right,
question.
no,
No
that was
problem.
from before. Yeah.
Okay, thank
Thank
you. Jody, thank you so much. And I'm sorry to rush you in and rush you out, because
You're
this is
okay.
something I'd love to spend some time on, and we'll have a chance, I think. And certainly we want to hear more about opportunities if it comes down to testimony or anything like that. I found that to be very rewarding and informative. So thank you
Greg,
for
I
coming.
do have a question though.
Okay, back to Ann.
Can you open it up to me? Is this something the Board of Health could make a recommendation to the BOCC to implement the tobacco license program and flavor restrictions?
I would be looking for that from the Board of Health personally as a BOCC member, but I'd also want to have the Public Health Department weigh in, because we'd have to get the information on just how many facilities, how many retail places that would actually affect in the community, and what we would actually be doing. Most of these retail places are probably within the municipalities, but I'm not certain.
Right. Well, it might be interesting to look at, because we did that over 3 years ago, City of Aspen. And it actually went fairly smoothly, and I think it's been pretty effective. So I certainly, as a Board of Health member, would support the staff looking into putting together those policies or the implementation.
And certainly I'd invite them to bring it to the BOCC too.
Yeah. Okay, thanks.
Great. Thank you. And Jody,
Greg,
thanks
if I
again.
could
Oh,
just say one
somebody
thing
else?
this is Jordana, and the only thing with the timing on this, we're happy to work on it as staff. Our current position for the tobacco coordinator for the STEP program is currently open. It will be posted soon if anyone is watching this and interested in the position. So our timing for pursuing additional policy work here would just be dependent on, once we get that position filled, being able to bring this forward, because we don't have the staff capacity to cover that unless we have that position filled.
Got it. Thank you, Jordana. I knew there'd be a wrinkle, but we're going to work that out, and we're going to keep moving forward on this. And this is a great campaign, and we've seen a lot of success. And thank you, Jody. Clearly, you're a dynamo that's making this happen for state and beyond. So thank you so much.
Thank you for allowing time. And if anybody has questions, please reach out to me. And again, appreciate all of your work. And Councilmember Mullins, thank you for the work in Aspen. It was a few short years ago, but it's been very impactful. So thank you for your leadership there.
Thank you.
Great. Thanks a lot. We're going to move on. It's time to get into the main attraction of the day, which is the COVID update. And I'm just going to hand it to Josh, Kim, Carly, Tracy, and Jordana. Take it away.
Well, thanks, Greg. Good afternoon, everyone. I wanted to start off by just clarifying a few things from the last meeting. We've heard that there's some confusion, and so just want to take some time to clarify those remarks so that confusion is cleared up moving forward. The first thing I wanted to discuss is our visitor vaccination status. And want to clarify that we do not have vaccination statuses of people that visit our county. We only have vaccination status of people that test positive here that we end up interviewing for a COVID-19 investigation. And so the data that was presented last meeting was using that data set of individuals that were not from here yet tested positive that we ended up interviewing. And so, in those interviews, we also talk about and try to identify how those individuals were exposed, whether they were exposed before they came to Pickens County or whether they were exposed when they were here in Pickens County. And then we also try to identify who they exposed, because that gives us an idea of whether or not those individuals are spreading the disease to other people. We do the same thing with our county residents as well, same interview process that we follow with them. And so, a few other points that I want to mention is, not everyone that visits here who has COVID ends up getting tested while they're here in Pickens County. We don't know how many people end up going back home and testing positive, and we never hear about it. So all we have is the data set from the individuals that visit here who test in Pickens County that then get reported to us. And the last point I want to make is, we use epidemiology, which is a statistical, really a statistical field and methodology that helps us determine what behaviors, situations, and events are statistically riskier than others. So we're not just looking simply at numbers and making projections or suggestions. We're actually taking the data and we're running it in statistical software to be able to know whether or not the information we're sharing is statistically valid or not. And so we don't just look at the data at face value, but we really look at it in a mathematical sense. So just wanted to make those few clarifications as it pertains to our visitor vaccination status. And then on the next slide, another piece that's come up a lot, and we can talk about it a little bit throughout this presentation, but is on breakthrough infections. And so I want to add a few clarifying remarks here as well. Just again, for clarity, a breakthrough infection is somebody that is fully vaccinated who ends up testing positive. Doesn't mean they have symptoms, doesn't mean they were hospitalized, just someone that tests positive who is fully vaccinated. So the first point that I do want to make here and clarify to make sure that we're all very clear on is that fully vaccinated people in general are less likely to be infected, they're less likely to be hospitalized, and they're less likely to die from COVID-19. A recent study out of Los Angeles County, their Department of Health, found that individuals that were unvaccinated were 5 times more likely to be infected than people that were fully vaccinated, and unvaccinated were 29 times more likely to be hospitalized than fully vaccinated. So when we talk about breakthrough infections, right, we are talking about a smaller subset of individuals, and there are reasons why we talk about it, which I'll discuss here in a second. But I do want to emphasize the vaccines that we have are extremely effective at preventing severe illness, hospitalization, and death. However, we do know that there are certain subsets of the population that can still test positive, develop symptoms, and can get severely ill, even though they are fully vaccinated. Those tend to be individuals that are older and individuals that are immunocompromised by far and large, by large. And so we do know that some fully vaccinated people who get COVID, they can transmit the virus to others, including transmitting it to other individuals that are fully vaccinated. Tends to be individuals that are older and those who are immunocompromised, although we've certainly seen spread among individuals that are not, that don't fall into those groups. So the question really is, why are we even talking about breakthrough infections if we're not concerned about severity of illness among the majority of the population? The reason why it's important is, most people in our community, most people across the country, across the world, they're thinking about, how do I not get sick, right? Most people aren't thinking about, am I going to get hospitalized or die? Am I going to die from COVID? They're thinking about, how do I just not get sick? Which is, why, we still have a lot of people, even if they're fully vaccinated or not, who wear masks, who distance, who still don't really go out about as much as they used to, because they don't want to get sick. Because if they get sick, it means they're out of work for at least 10 days, right? Which is going to impact them financially and in many other ways. And there's also, of course, risk of long haul COVID. So, whether or not people are vaccinated or not, right, people don't want to get sick. And so informing people that, although the risk of severe illness is lower, you can still get infected, right? And most people just don't want to be infected. So making sure that information is clear to people, that, the risk is still there. It's less, but it's still there, is important to communicate. Each person needs to perceive their susceptibility and understand the risks involved. Again, I just want to emphasize that, in our contact tracing that we do at the county, the goal of epidemiology, yes, it's to prevent mortality, but it's also to prevent morbidity. Because we know that if we can prevent people from getting sick, then they can't be hospitalized and they can't die from that illness. So, we're thinking about this really in a two-pronged way, which is that we want to prevent mortality. We also want to prevent morbidity, or people getting sick in general. And so when we talk about breakthrough infections, really we're just talking about, how do we prevent people from getting sick? And then how do we prevent those individuals from then passing it on to somebody else who might be more susceptible, even if they are fully vaccinated? So I just wanted to provide those sort of clarifying remarks that, we definitely are monitoring breakthrough infections very carefully, because we want people to be healthy. We want to reduce the prevalence of COVID in our community, and we want people to understand risks of infection, whether or not you're vaccinated or not. So just want to provide those remarks before jumping into the conversation here.
Great. Thanks, Josh. Just keep in mind, we're started a little bit late on this one, and so I'm going to want to keep us moving at a brisk pace. So thank you.
Next slide. So this map here is looking at hotspots that are across the country right now. So over on the left-hand map, we have where the hotspots across the country were on the 23rd of August. Then the right-hand map is looking at September 8th. And so what you'll notice is that there's really this effect of spread from the Southeast to other parts across the country at this point. And so the circles on the map are identifying places on the left where risk was lower. And now 2 weeks later, we're seeing an increase in risk in those areas. And so you can see it's really spreading out from the Southeast to other areas of the country. So, while we're in this peak right now of cases and, we're definitely feeling the effect, especially in the Southeast from the Delta variant. There is anticipation that these cases may begin to expand out into other parts of the country, and we may not really see this decline in cases, but we may continue to see an increase in cases as COVID spreads to other parts of the country, even though these other parts of the country are more highly vaccinated. Case counts this Labor Day were 3 times higher than last Labor Day across the country. Next slide. So this is looking at our incidence rate here in Pickens County from the very beginning of the pandemic until just 2 days ago. And the main thing that I want to highlight here is where we are this year compared to where we were last year. So our incidence rate on the 7th of September last year was 28 cases per 100,000 individuals. On the 7th of this year, our incidence was 253, which is 9 times higher than a year ago. So, everything taken relatively, it feels like because we had such a large peak in January, we're in a better place right now, but really we're 9 times higher than where we were last year when we really began to ramp up and see an increase in cases over the next couple of months. So that context, I think, is important to understand as we're trying to interpret where we are in terms of COVID. Next slide. So this is just our cases by week. So we've had 45 cases reported over the past week. You can see in the week prior, there was only 40, week prior to that 41, and then the week before that 19. So really the last 3 weeks, we've been averaging about 40 to 45 cases every week. We still have a large proportion of individuals that are unvaccinated who are testing positive. 31% in this most recent week were unvaccinated, despite our vaccination rate being significantly higher than that. So there is still a much more substantial risk to individuals that are unvaccinated. And then we've had 7 cases among children, which is about 16% of all of our cases, which is lower than the national average. Right now, about 27% of all cases across the country are among children. We're at about 16% at this point. And then our visitor cases are still remaining pretty high, anywhere from 20 to 40%. So we're still monitoring those pretty carefully. And then the last thing I want to mention is we have had 2 hospitalizations between the 1st and the 7th of September. So as our cases have increased, we have had 2 county residents that have been hospitalized. We've had other individuals that have been visiting who have also been hospitalized recently, but 2 of our county residents have been hospitalized. We haven't had any deaths recently, although of course, anytime we have a hospital admission, we're of course monitoring those individuals very carefully. Next slide. And so, we presented this a while ago looking at our fatality rate, but wanted to highlight this again about where we're at compared to other counties in Colorado. So this is showing the fatality rate per county based on the total number of cases that we've had. So in Pickens County to date, we've only had 4 deaths due to COVID-19 out of close to 3,000 cases. And so that puts us really at the very bottom in terms of our fatality rate. So while we had the highest incidence rate for several weeks back in January and February, we knew that we were capturing a lot of cases because a lot of individuals were being tested. And so, we sort of take that testing rate and look at, where our fatality rate is. And, yeah, our incidence rate was high, but we were capturing a lot of cases and we were actually probably containing the virus better, even though our incidence rate looked high. And because of that, our fatality rate has remained lower. The only 2 counties below us, Hinsdale and Jackson, they've only reported 49 and 70 cases total throughout the entire pandemic, and are very small counties. So overall, our fatality rate is very low compared to others in the state and across the country. But this is also a call to action to ensure that we continue to ensure that our case fatality rate remains low by protecting our community moving into the fall and the winter. Next slide. One quick study that I'll just go over real quick did find that children were much more likely to have higher rates of hospitalization in states that had lower vaccination rates. So they lumped all the 50 states into 4 categories based on their vaccination rates. Colorado fell into the second highest there. But based on where your vaccination rate fell in the state, there was a very strong association with increased risk of hospitalization among children. And so, if we take this data from a state level, put it into a county level, we know that when there's a higher vaccination rate, we're actually protecting our children. So again, another reason why vaccination is so important, protects other people in the community, not just yourself, especially children. Next slide. And then, one other thing that I just, want to sort of mention as we start talking about booster doses and additional doses becoming available is, Pfizer and Moderna, issued a 2-dose vaccine series. And, I think what some of the science is looking at right now is 2 doses enough or 3 doses going to be required for certain individuals. There are many other vaccine series that are out there that require more than 2 doses. The DTaP requiring 5, others requiring 4, others requiring 3. And so, even if COVID ends up in a 3 or 4 dose series at some point, which may or may not happen, right? The science is still, pending on that. That wouldn't be abnormal, right? We have other vaccines that are also requiring a higher dose. So, in order to get the maximum benefit, we may require more than 2 doses at some point, just depending on, how the virus continues to mutate. So just wanted to kind of start that conversation as we begin to start, as Carly starts to kind of, provide more information to us on booster doses. Next slide. And then really finally, before I hand it off to Dr. Levin, is looking at our rates of influenza-like illness and RSV. So right now we are seeing unseasonally high rates of RSV. And we know that our rates of individuals that are reporting to emergency departments with influenza-like illness is also much higher than it normally is, especially among young children. There's definitely a lot of concern moving into this winter. We were concerned about it last winter, but because everyone was masking, we ended up not seeing very many flu cases across the country. There was a lot of concern moving into this flu season that because we didn't have a lot of flu around last year, this flu season may actually end up being worse than it has in the past couple of years. And so, again, just a call to action that the things that we've been doing and putting into place are not just protective against COVID, masking, distancing, washing our hands, those are all protective against other respiratory illnesses as well. And as we're trying to keep schools open, trying to keep people healthy, recognizing the importance of vaccination and all those other mitigation strategies is going to be extremely important as we move into this flu season to ensure that we keep our hospital capacity at levels that we can still support individuals that need to be seen at the hospital for non-COVID reasons as well. Next slide. And so I think I'll pass it off to Dr. Levin at this point.
Thanks, Josh. Yeah, and that last point, thank you. I appreciate you bringing it up. I think the conversation is not appreciated as much right now as it might be when these other respiratory illnesses cause hospitalizations and additional stress in the hospital. So I'll just shift to the hospital. The hospital picture, I just wanted to put this graph up from the state level and showing these are patients currently hospitalized for COVID-19 in the state, and just the sharp rise as we have from July 1st up to the present, not knowing where we're going to be going. And this really paints a picture of what's happening throughout the state, where we're transferring, our potential transfers are for patients. We're at about almost 1,000. It's 969, I think, today. And that was the sharp rise in the middle of beginning of January, end of December. All right, next slide. And one more slide before I look at show the hospital matrix is which I think is so important for us, again, this ability to transfer. So if we cannot take care of a COVID patient, if a COVID patient requires an ICU bed and our ICU is filled, we need to transfer this patient. And if you look at the Northwest, that's where St. Mary's Hospital is, which is one of our main transfer routes for COVID patients. There's only 19% of ICU beds available at this point, 19% available. And then we checked yesterday with the hospital system. It looked like that amounted to 2 ICU beds there that are available. So really tight. And then looking at the Mile High area, which is in Denver, 13% available. That's where a lot of our patients are transferred. And again, to mention non-COVID patients, the ability to transfer them into a really very tightening system at this point. So I think the Denver hospitals are tight. Some of them are on divert. Some of them are really showing a lot of stress. And that, although we don't see that here, it really impacts our ability to transfer. So and these are the RETAC regions. There's 11 of them. Okay, next slide, please. So this is the Aspen Valley Hospital matrix, and Dave Ressler is also on the call and we'll make some comments. I just wanted to present what's happening here. And just to update you, I know we haven't looked at this in several months. Thank goodness we haven't had to, and now we do return to it. As of today, the current status of the AVH capacity has increased from comfortable to cautious, and it's been increased on all 3 components. So the healthcare worker, the average daily visit, and then the inpatient hospitalization / transfer capacity, which puts it at an overall cautious level. And while currently the capacity is manageable right now, this in each of these categories, there's just some stress that's occurring. And there's levels, if we look at these threshold levels, that we are wavering right at and right above. And that's really what put us in the cautious level. So if you look at the healthcare workers on the left, we're at about 6 right now. In the average daily visits, the ED in the emergency department, we're hovering around 6 as well, which puts us from the green to the yellow. And then inpatient hospitalizations, the ICU beds, there are currently 3 of 4 that are occupied, and 2 are with COVID patients. So things are happening, and there's an overall increased stress level at the hospital. And if you look at healthcare workers, really 6 doesn't sound like a lot, but if it's in one department, in a small department, it really puts a lot of stress in that department and the ability for the hospital to function. So this is news today, and I just wanted to see if Dave had some comments or there's questions about it.
Thank you, Dr. Levin, and appreciate being part of the conversation again. And I think you explained our rationale for increasing to cautious quite well, along with the representation that you provided about what's happening statewide with hospitals, because we have to remember that we're just part of a larger system. And to your point, with 13 and 19% availability of ICU beds at our referral centers in Grand Junction and Denver, what that really means to us is we may not have the ability to transfer, may find more difficulty with transferring patients, having to wait at times when we have to. And so we have to be able to look at our own capacity with that in mind, that we may end up keeping patients for longer than we would otherwise want to. So it's part of a larger picture. And as you described very adequately or very well, the essential healthcare workers is something we're particularly concerned about because typically we are seeing that when we do have employees out ill and with COVID symptoms, much less a COVID positive test, it tends to happen in groups and it tends to happen in departments. And so we're exercising all of our precautions to protect our staff. We have a very high vaccination rate, which also is an important determinant of how well we're able to manage these. But it's just a factor of, or a function of how much spread there is in the community. And that's our greatest concern. So as the incidence rate climbs, as you heard from Josh, and I hadn't known that, 9 times higher than a year ago. And we're still, I think it's important to point out, in the midst of a very busy season. So we really just started. I don't think we've seen the impact yet. It hasn't been long enough to see what's going to happen after the Labor Day weekend and all the large events that have been occurring in the community. As well run as they've been, we have a lot of people in town. The only other point I want to make is with regard to testing. And presently, we're right at the threshold of community testing. And remember, that's just what comes to ABH. And we require a physician's referral, as we are required to as a licensed hospital. There are a lot of other tests, obviously, going to the community testing that's available through other sources. So ours is just one piece of the larger indication of how much testing is occurring, which you've heard from Josh, which is a good thing, but it's indicative of the fact that there's just more activity in the community. And I said that was my final point. I do want to just conclude with Dr. Levin's comment about our ICU. We actually had all 4 ICU beds occupied this morning. That's kind of a changing factor over the course of any given period of time. But we really have had some very high acuity patients in the ICU, both COVID and non-COVID. And so it doesn't take much, is my point, and the point Dr. Levin was making, to stress our system. So we don't want to wait until we're overwhelmed. We want to be forthright with yourselves and the community about where we stand. And right now we're cautious. I think it's really the best way of describing our current status. So thank you, Dr. Levin, for walking through that.
Thank you, Dave. I appreciate it. All those comments. I did want to add that as we've seen throughout the pandemic, the burden of virus or the load of virus in the community really does reflect what happens in the hospital. And we're seeing some of the healthcare workers out in particular departments that are stressed. And the concept that the higher number of cases that you have, which, as Josh has outlined, is really starting to spike, will put others who are vulnerable at risk. So although many people are getting mild symptoms and the vaccine is really working well to prevent hospitalization, the higher number of cases that you have in a community, the more risk you put at the vulnerable population, being the pediatric population, which we know that the Delta virus variant is really causing a lot more pediatric, a big spike in pediatric hospitalizations across the United States and a higher number of pediatric infections. And we know here in Colorado, Children's Hospital is our main hospital that we would transfer a pediatric patient to. And that hospital is actually a regional transfer center. So it accepts patients from multi-state, from other states surrounding as well. It's a really centralized children's hospital. And so that puts stress on it, as well as our only real main transfer center for a pediatric patient. Looking out for that. And the other vulnerable are, of course, the immunocompromised, who do not create antibodies at as high of a level as a a person who's not immunocompromised normal. So we have to, that's the whole concept of herd immunity, where we have to have the highest level of vaccination rates among the people that can be vaccinated to protect the others that cannot be, or who are vulnerable to having severe infection or hospitalization if they get the virus. So another argument for really vaccinating as a solution here, and also masking and social distancing. We know masking works. I'm really looking forward to the conversation of indoor masking policy and how that can improve and decrease transmission in our community here. So I think that was my main main points. And a policy around masking, I think, can simplify and really help some businesses out who need it in terms of guidance. So any questions about the hospital matrix? Any other points?
See Krista?
Thanks. I just did want to add from my friends that work at Denver Health in the ICU there that they are getting a lot of out-of-state transfers right now too, which is affecting their capacity. 50% of their patients are coming from out of state. They have told me that 50% are coming from rural areas of Colorado. They're not having a lot in Denver, and that 100% of the Denver Health ICU right now is unvaccinated COVID. That is who is in the ICU in Denver. So I just want to make sure we stress this point over and over again, that there are these other mitigation strategies, but the vaccination thing is still front and center, especially for ICU.
Thank you. Any other questions, comments? I had a question of this about somebody who follows the statistics and the curves, and I was trying to ask them if they could predict. Early on in the pandemic, they were predicting spikes, and they were doing it with pretty good accuracy. And I'm just wondering, given the variants and given the various circumstances, can we predict the next spike, for instance, or the next trough with much accuracy? And is this a science that's evolving? Maybe Josh could answer that real quickly. I just trying to think. We all want to look into our crystal ball as the coming winter comes, and I think maybe this will help segue us into that conversation when it's appropriate with Jordana. But I'm just wondering, how good is our predictive science on the next spike?
Greg, yeah, definitely a lot of organizations and governments have tried to predict, and for the most part, it hasn't gone too well, especially when trying to predict months into the future. The CDC has a forecasting site on their website, and they try to predict about 4 weeks into the future, but they don't go beyond that just because there are so many unknowns. So I'd say in terms of trying to understand what the winter might look like, that's probably going to be very hard to predict. Trying to understand what might happen over the next 2 or 3 weeks would probably be, that data would be a lot more accurate.
I agree with Josh. I think it's almost impossible to really predict. I think we know what the tools are that work, and we focus on those the best that we can, which is vaccination and masking and staying home when you're sick and getting tested. And I think those are the real tools we have. And there's been so many different predictions, and hindsight is 2020.
Thanks, Dr. Levin. Okay, moving along. Jordana, are you next in the queue, or?
I think we go to the next slide. I think it's Carly.
Carly.
Hi, everyone. Thank you guys for having me again. I feel like it's been a while since I've presented here. So just a quick general update on sort of the status of the vaccination effort within Pickens County. I really want to start with a big thank you and kind of a statement of the success that we've been able to have, thanks to the Board of Health, thanks to our physicians, thanks to the community, the hosts. I mean, it really has been an incredibly overwhelming outpouring of support from kind of all fronts. And I feel really fortunate to be part of the community. I feel really fortunate to be helping lead the vaccination team through this kind of summer phase that we found ourselves. And so notably, I just want to highlight that we are kind of second in the state for our vaccination rate from the state data. That's about 91.9% of all eligible population having received at least one dose. That puts us actually higher than many, many counties in the United States. And so it really is very, very impressive. I think I also want to highlight our kids vaccination rates as 12 to 17-year-olds is huge, is 71% and growing as we're working with the schools to administer more vaccines in that school setting. And then a really big shout out to kind of our equity team. Over the summer, we've had 22 public facing clinics. And it has been 30% self-identified Latinx, which is, again, a very large number for Pickens County. And kind of, I think in general, shows our willingness to kind of be open and reducing those barriers, not saying that we found the perfect system, but really kind of showing the work that team has really done on working on those processes. Really big shout out, notably also to the city of Aspen for letting us host those public clinics on the mall. That was really powerful and really transformative. The number of questions that we had there that we were able to help answer and talk about hesitancy and concerns was huge. The Snowmass Center was also massive. That was probably, we saw the largest numbers come through that Snowmass Center clinic, which was really, really exciting to see. And then a really big shout out to our street team members. They have been on the ground, knocking on doors, talking to businesses, really being the face of this kind of vaccine campaign, there to help schedule, there to help answer any kind of questions. There was a lot of really tough conversations about hesitancy and about misinformation. And I can't thank the DI team enough. Greg Polschman, you were there a few days. Thank you for coming by. It really was such an incredible kind of tool to be able to challenge some of that misinformation that's going around. And we saw tangible results of people that we spoke to one day who said they would never get a vaccine coming through the clinic the next day. And that's really, really cool. So I just wanted to start on this very high note of thanking everyone for kind of going through this and really highlighting that the effort has been tremendous and it is paid off. You know, we see that the success, we're not done by any means, but to this point, we've done a really, really awesome job. So thank you all here. Next slide, please. Now the fun stuff. So additional doses and kind of where we are now. There are 2 different phases that we're kind of looking at approvals for administration of additional doses. So I'm going to talk first about who is eligible currently, and then the next slide talk about who we believe is going to become eligible later this month, and then talk about kind of processes and pathways for both of these populations. So individuals who are currently eligible for the COVID-19, for an additional dose of the COVID-19 vaccines, are moderately to severely immunocompromised. The conditions that kind of fall under that category are listed on the slide. I'm not going to read them to you. They're many syllables long. And the really big push with this is that these are individuals who are at extreme risk, that they likely did not mount an adequate immune response to that initial dose regime. And so the FDA and the CDC really wanted to allow these individuals access to an additional dose at this time in order to counteract that immunocompromising condition. I really want to highlight the fact that this is a limited group of individuals with incredibly complex medical conditions, and not everyone who is immunocompromised falls under this category. A really big push, or the 2 things that we hear a lot of questions regarding, is that ultimately it's also not for individuals with low antibody counts. We've heard that come out of the community quite a bit. Low antibody counts are not listed on the CDC or the ACIP guidance. And so in order to continue to administer on label, following that ACIP guidance to a T, we really have to be considerate and respectful of kind of these individuals who are at risk, prioritizing their access to vaccinations at this stage. Big push here is really putting the focus on these patients and their care teams or their primary care physicians. So really putting these patients in contact with those care teams who know their conditions inside and out, and can really assist them in making the choice or the decision if that additional dose is correct for them at this time. For a good portion of these individuals, that might not even be the case, is even if they are eligible at the course in their treatment that they find themselves today, might not be the best time to receive a COVID-19 vaccination. And so really kind of having them, encouraging these individuals to go speak to their care teams to determine that eligibility. So that's kind of where we find ourselves now, is that there is this small subset of the population of at-risk individuals who are eligible, but a vast majority of individuals who are seeking additional doses are not currently eligible, but are hopefully going to become eligible later this month, if not through the following months. So next slide. So additional doses for the general public. This is a interesting and nuanced conversation regarding efficacy, regarding the complex immune responses to vaccines. And the really big push is that there really has been data that shows that individuals who are vaccinated at the beginning of the pandemics or the beginning of the vaccination campaigns globally, so in December 2020 and January 2021, we are seeing breakthrough infections within those populations. And that came from a study from out of Israel. Some of the critiques revolving around this is that the vast majority of individuals who are vaccinated at this time are older, so our 65 plus population, who potentially were not able to mount an appropriate or adequate or strong immune response to that initial dose regimen, as well as frontline workers or healthcare workers who inherently have a higher risk of coming into contact with COVID positive patients. There's various critiques also about the fact that there's no direct data supporting that the vaccine efficacy is waning. So the idea that our bodies are not able to mount that immune response anymore, it's hard to disprove a negative, right? And so the really big push is to err on the side of caution, and that functionally we don't believe that there are any downsides to administering additional doses. There is a few studies coming out of some countries that are doing so, showing that there is an increase in that protection. And so that is what the CDC and the FDA are really trying to kind of focus on when hearing these arguments and looking at the data to determine if administering additional doses to the general public is the appropriate thing to do at this time. I also really want to highlight that there is no silver bullet for this pandemic. I know that Josh did an excellent job going through the nitty-gritty data, and that I think, unfortunately, we have to go back and kind of look at that Swiss cheese model of protection, and that vaccines are an incredible tool. We see that they're reducing hospitalizations. We see that they're reducing deaths. We know that they are offering strong protections. And that ultimately, I think I was talking to a partner yesterday and they stated that the vaccine is only as effective as you make it. And that if you are vaccinated and treating it as a golden ticket to kind of engage in unprotected behaviors, whether that's concerts or going maskless or not washing your hands or not quarantining, there is a potential that you could catch COVID-19. And I think the really big push to really highlight that the healthy best practices on top of getting vaccinated is really going to increase that protection, increase the effectiveness of the vaccines, and really keep you from getting sick. And so I think really just highlighting that. I think a really big push for the date that the federal government is looking at for approval. They stated from the Office of the President that they were hearing arguments before September 20th and are hoping to start administering additional doses to the general public starting that week. Most other things that we know are a little bit convoluted, and we ultimately might not know much about what that approval looks like until the day of. They initially stated that Pfizer and Moderna were going to be approved at the same time. It now looks like there may be delays in acquiring the Moderna data, and so we are currently looking potentially at a Pfizer approval for additional doses in those 16 years and older around September 20th. At this time, Johnson & Johnson has not submitted data or has not stated that they have intentions to do so for this foreseeable future. So currently what we're looking at is Moderna and Pfizer likely being approved soon after the other, if not at the same time, sometime around September 20th. And that mixing and matching is still not going to be approved, which means that if you got Pfizer for your initial dose, you should get Pfizer for your third dose. And that really kind of pushing that that's the big question mark we keep getting from Johnson & Johnson is that if I got Johnson & Johnson, can I get Moderna or Pfizer? And at this time, the answer is no. Really big effort at the end of the month to focus on community clinics that can accept these third dose interests. So currently, third doses are not being held at community clinics through town just due to medical complexities. But we have worked with our community partners in order to set up larger scale clinics in Aspen, in Snowmass, in order to kind of accommodate what we're anticipating to be an increased demand for these third doses. So next slide. And this is sort of the process for both of these kind of current eligibility and what we anticipate to be future eligibility. So for the currently eligible, we have been in contact with our local physicians and practices and set up a referral process. The really big issue that we had is that it has to be they have to be administered following that ACIP guidance for that medical condition and eligibility. And due to the medical complexities and the medical vulnerabilities of the currently eligible, we need to administer those doses within a clinical setting. So those public clinics that we've been having on the mall and at the Snowmass Center just isn't the correct and safest option to administer those doses. So any physician, we sent it out with Dr. Bernard. I sent it out personally to quite a few, if not all of the offices, with a referral form. So if you have been talking to your patients and if they are eligible, please refer them over to us. Thus far, everyone who has been referred has been scheduled with us, which is really exciting. And so really trying to, again, put the onus and kind of the focus on that conversation with patients and doctors, is that this should be a conversation about the medical care for that individual patient. From that referral form, Pickens County Public Health will then reach out to the patient in order to schedule that appointment with them for them at Community Health Services. So you cannot contact Community Health Services separately. So please reach out to us if you have any questions regarding that referral process. For the general public, we have launched an additional dose interest form. If any of y'all remember the vaccine notices that were set up kind of mid-winter last year, this is an echo of that process. What the additional dose interest form does is it is not the same sort of constant contact that the vaccine notices were. It is really utilized for planning purposes. So really trying to get a tally of what the numbers are for what type of vaccine based on which month that it was administered for. And that is going to really, really help me and kind of the team know when to schedule clinics and how much vaccine to order. And really look at that volume. So again, even though we have multiple clinics planned for the end of September, early October, that can accommodate the additional dose appointments, we really want to look at kind of this longer term, what needs to be done on what month and how many people to really make sure that we can meet that community need. What will happen once that form gets filled out is we do ask for preferred contact information. And so as soon as we know anything about the approval process or where we are and what gets approved, what doesn't, and the potential time frame for that approval, we are going to contact individuals through their kind of provided information in order to alert them of not only that we've received that approval, but also to highlight scheduling opportunities that are taking place for that. Really big push again for first and second doses. We know that we have a really high vaccination rate, but knowing that there are populations that haven't been able to access vaccination for various reasons, and especially looking forward for if/when we get approval for any of the vaccines for that younger childhood age group, that Pickens County Public Health really does want to focus on those first and second doses for those populations who really haven't had a chance to access the vaccination process as of yet. A really big effort that's happened in the last couple of weeks has been talking to our medical providers in the Valley and within Pickens County to become vaccination administration centers, which is really exciting. So we have had quite a bit of movement on that this week. I've personally talked to at least 4 clinics, 4 offices who have stated interest and have actually initiated that application process. And so especially when we're looking at our vulnerable populations, our younger children, being able to receive that vaccination at their trusted care provider can be huge. That could be the difference between a parent choosing to get their child vaccinated if they have to come to a gymnasium or if they get to go talk to their pediatrician. And so that's been a really big effort in the last couple of weeks. And I want to thank all the providers who have engaged with that process. I know it can be daunting. I know it can be a lot. But it's really exciting to see that uptake starting. So,
thank you, Carly. I really appreciate that. Everybody is rushing, I know, and we are behind schedule. We have a lot to cover still before we get to round robin, which will probably be truncated. But I think we're going to cover a lot of what would happen in round robin in the next presentation. So I'm going to hand it back to Jordana and Tracy, who is coming on with this, and let's see how far we can get in the next half hour because we have a hard stop at 3:30. Thank you.
Good afternoon. I believe I know everyone here already. My name is Tracy Truelove, and I'm one of the PIOs on the COVID response for Pitkin County. I will try to go quickly. Usually comms people can make up some time. We'll try. So our strategy for the fall, and I'll just go into, is in concert with the public health team, and that's to keep our locals and anyone visiting current on the status of COVID-19 in our community. Our prevention and management strategy, our vaccine testing and masks, and I'll go more into that. And really the thing that we encourage and have such a great rapport already with is amplifying our message through our other partners. So that's digital and traditional media, and that's through all these partnerships we've built over the last 18, 19 months. I kind of lose track. Our audiences are local residents, businesses, the owners and employees and visitors. Next slide, please. I think it's just important to remind everyone of the communications tools and platforms that we will continue to use and are using. Our website is our workhorse. It's the place where we update information. It's a very easy to find site to get anything you need to know about what's happening in the community. It has a vaccine location finder, a testing site finder, and it's where you'll see our mass guidance. Our newsletter is another tool that we've been using frequently to provide updates on what's happening on the national and local level. And if you haven't signed up for it, we encourage you to do that. We found a few times where people who were confused hadn't even, found our newsletter as a great tool and resource. Our social media channels remain active and have been now for a long time. And something new that we'll talk about here quickly is the weekly data summary, and I'll get to that in another slide in a minute. And then we have tremendous engagement with the community on our COVID info line. Next slide, please. So just to show you a little bit or talk a little bit about the website, it's really a tool that, again, we continue to refine. We continue to make it as easy for people to find information as possible. And as I get into the next slides, I'll be able to talk a little bit about the statistics of who is finding us and the engagement we have. One of the things we're very proud of is that it is a bilingual. You can click on the English or Spanish button and go into a completely bilingual site. But we've made it as simple as possible to go find how to get vaccinated, how to get tested, and mask guidelines or information that people need to know about what's happening in the community right now. Next slide, please. So let me talk about website statistics. So the website really seems to traffic really seems to mirror the national COVID-19 case statistics. So when they go up, the website traffic seems to increase for us as well. So on this slide, you'll see we had a pretty good, lull in June and July. Next slide, please. But we are starting to see an uptick in the last 2 months of interest locally in our site. If you Google COVID Aspen, COVID Pitkin County, any of those things, our site is the first thing that is listed in the search engine optimization. Go ahead and next slide, please. So the newsletter is also another great tool that we provide a lot of information that's coming out on the national and local level. Our database for people who've signed up is over 2,000 folks, and we do have an average open rate of about 50%. That's actually, if you've ever done newsletters in your lifetime, is a really great open percentage. Next slide, please. This is a little bit about our social statistics. We definitely in the early stages of the pandemic saw a tremendous amount of engagement on the Facebook page. But I think a lot of what we're seeing again in that lull is that when Colorado kind of changed a mandated message around COVID to a more prevention and education piece of what we're doing, you started to see people not engage with any of our platforms the same. We are seeing that change now. Next slide, please. Our data summary is something that's just come online. And again, you can sign up for our data summary through our newsletter database, but that's a report that we're sending out on Thursdays. And we've just already found that people wanted that quick hit of information, and that's tracking with our data team. So that's how we're going to keep people up to date on kind of what the latest statistics are. And that ties back to what Dr. Levin was sharing about the hospitalization metric as well. Just, people want to know in our community what that looks like. Next slide, please. So a couple of times the team has mentioned healthy best practices. I believe early in the pandemic, you all remember the 5 commitments, and we recognize the 5 commitments kind of started to lose their power, and we decided to move again to that prevention education space. And that's something that public health is, renowned for. And so our team came up with the COVID healthy best practices. And you'll see that we're still amplifying, get vaccinated, masking up when appropriate. So in those indoor spaces, stay home if you're sick, getting tested, and, continuing to wash your hands. And so for the fall, you're going to see us continue to take this message that's been out in the community, but amplify it even further. And a lot of what's happening is our stakeholder engagement with our tourism partners is definitely started to come back online as well. But this is a little bit, that was Tracy's super speed update. But, I guess I should just really share is that the COVID comms team, we're currently about a group of 7 of us. And 3 of those folks are very young, savvy interns that the county has committed to having on board. And, they're teaching some of us old timers some new tricks. And there's always room for improvement. There's always room for feedback. And it's a team that really has taken any kind of feedback we get and pivoted to a direction that we believe is ultimately providing the best communications. The fact that we're the second in the state, and that was a big part of our push for May, June, and July, would share that the message was getting out. We were trying innovative things. And I think the county has dedicated the resource of our COVID info line. Rosa Saucedo, who's on our team, is a multicultural bilingual member of our team who I've never seen work harder to try to help people get the answers that they're looking for. So we don't just rely on the one channel of the website. We do have other places to engage with us. And with that said, I'm going to stop, and I'm sure at some point there's going to be questions.
Thanks, Tracy. That's great. I really appreciate it. And this is great. It looks great to me. If I can, I'm just going to move us right along. So Jordana, pivoting to you.
Absolutely. We can advance the slide. This first slide, I think, speaks to what many have already touched on today. Vaccinations continue to be our most valuable prevention tool here. We know in Colorado, the unvaccinated are currently the majority of cases, majority of hospitalizations, majority of deaths. The value that quarantine is not required when a fully vaccinated person is exposed to a positive case is a benefit for individuals who are fully vaccinated, as well as employers wanting to maintain staff while working, trying to operate businesses and organizations throughout a pandemic. And then we have already shared vaccination status that we are 84% of our total population of Pickens County has had at least 1 dose, 65% been fully vaccinated. Next slide. Why the vax need to mask? So just covering this really briefly, we understand that masking continues to be our second most valuable prevention strategy. Before the vaccine, we had to only resort to shutdowns, masking, social distancing. We had fewer tools. Now we know we were seeing really early on when the vaccine came into play that it was preventing very well against severe disease, hospitalization, and even transmission. Now that Delta's here, we're seeing more transmission, even among those that have been vaccinated. We know that we need to encourage masking back into the fold of how we prevent transmission. Next slide, please. This is a slide I stole from Boulder County. It just gives us an idea of the different tools that we have as public health in our toolbox. We've been through many of these in the past year and a half. And if you look over on the left-hand side, those are the less invasive, less burdensome strategies. So contact investigation, contact tracing, isolation of cases, we will continue to do. Hygiene, ventilation, vaccinations, testing, quarantines, and then indoor masking, pods, asymptomatic testing get a little bit more burdensome. And then we know, as we work down into capacity limits or community lockdown, business closures, those are extremely burdensome in our community, and tools that we don't want to have to implement. The more we focus on the left-hand side of this strategy, the more we're going to be able to protect our hospital capacity and move us into a successful winter season. So if we look at the next slide, we're going to delve into a little bit around this vaccination strategy. We know that increasing the fully vaccinated individuals in the community is going to be incredibly helpful for all of us. In blue is what public health has been doing and will continue to focus on. So Carly spoke about some of these. And then, really making vaccines available. And then in orange are the roles that businesses and organizations can help play, especially around vaccination. Incentivizing or requiring vaccinations among employees is incredibly helpful in boosting vaccination rates, as well as allows businesses to really take on that leadership role in the community. Second, nope, still get out of here.
Mama, I'm just gonna be here.
That was Steele. So for vaccination, what we're also asking of businesses is to incentivize or require vaccinations among patrons and visitors. And so I think this is going to be a strategy that we really want to be thinking about as we're preparing for winter. What does that mean? How can we work with our ACRA partners, our business partners, and anyone who has contact with those visitors coming into the community to incentivize or require however we want to do it, increase that vaccination rate. John Peacock, thank you for forwarding me this article that Biden is planning to announce a vaccination mandate for businesses with 100 or more employees. Sometime today. So things always like to happen on our Board of Health meetings, that those businesses are going to be required to either have employees get vaccinated or test weekly. Next slide, please. I think this is a hot topic that I know the Board of Health is eager to discuss. So we understand, again, masking is an incredibly effective strategy to reduce transmission. These are the areas where they are currently required on public transportation. That was extended through January. That's a federal mandate. Masks are required in schools and childcare settings, thanks to the Board of Health for passing this last month when we met, and also to the support from all of the school district and other schools in the county for supporting this and enforcing this. Masks are currently required for unvaccinated or not fully vaccinated individuals in settings that serve vulnerable or at-risk populations. That is currently in the state public health order. And then this last piece about masks being worn indoors when community transmission is substantial or high is a CDC recommendation, one that we absolutely endorse and strongly recommend here in Pickens County. And so what we have been doing is communication and education around this CDC recommendation, and have been reaching out to our business partners and organizations to encourage them to require or recommend masks for employees and our patrons when we are in these substantial or high levels of transmission, which we currently are. If we go to the next slide, we delve into this masking issue a little bit more. So really understanding that our goal is to increase indoor masking compliance in the community, which helps decrease transmission. And as I think Dr. Levin very clearly stated, decreases hospitalizations of those most vulnerable. We know the vaccine does a great job of protecting against severe hospitalizations or severe illness and hospitalizations and deaths among the majority of individuals. But those who are not able to be vaccinated, too young, or haven't been vaccinated, or are immunocompromised or older, that's where we're seeing the hospitalizations. That's where we're really understanding the threats to our hospital capacity to be. So the options when we're thinking about how to increase indoor masking compliance, the first decision really is this a recommendation versus a requirement? When we understand that recommendations versus requirements, we really start to get into some behavioral and psychological understandings of why people are choosing to do something, one thing over another. We have set in our community that the criteria for implementing a requirement would be once our hospital capacity is threatened locally. So really keeping that in mind as we have this discussion. And understanding the differences in recommendations versus requirements. We understand that requirements there have been many studies that have shown if you have a mask requirement, you're going to increase the number of folks who are masking in the community, and that recommendations are still, they're out there, and what we're hearing in the community are still being seen as an individual's choice to follow that recommendation or not. We have seen different uptake with businesses saying, we hear that it's a recommendation, and we're gonna leave it to everyone's choice until it becomes a requirement. But we've also seen, on the other hand, a more select group of businesses or organizations who have stepped up to play that leadership role in modeling, setting that policy level at the organization or business level, and to demonstrate that it is important, it makes sense for people's health, and it makes sense for continuing to have people come in, be healthy, and keep businesses and organizations operational, decrease healthcare costs, the whole gambit. The point that always comes up when we talk about doing something in Pickens County that is stricter than our neighboring counties or the state is the alignment question. So if we are different than our neighbors, well, what is that? That becomes a difficult message sometimes to get across, especially to those that maybe live in a different county and work here and are visiting here. We've been told in the past that becomes a more difficult message to clearly communicate. And then finally, this point about the expectation of enforcement. With a recommendation, there is no expectation of enforcement. With a requirement, there is that expectation. So that normally gets you probably more buy-in, but then also we realize that we don't have the capacity, whether it's with our public safety officials or the public health department, to be responding to every report that indoor masking isn't being adhered to at 100% level. So, we really need, if when something becomes a requirement, where we see success, like in the schools, is that we have the buy-in from those that are on the front lines and needing to enforce a requirement and understand the importance, so that it can be an expectation throughout the community. For reference, I just want to share some things that we've seen throughout Colorado. So San Juan Basin has issued some public health advisories where they're clearly advising the community what should be done around wearing masks, around vaccination, around distancing, and all of the preventive measures we know work, but in a more formal format. And then Boulder County is, to my knowledge, the only county who does currently have an indoor mask requirement in the state of Colorado. And so if we want to learn more about that, I've got a slide with some information. So Greg, I don't know if you want to open it up to conversation there for the board.
Thank you. I appreciate it. I know we're looking at the clock. We're pressed for time, yet this is the crux of the conversation here. Does anyone want to throw a question, or should we look at what Boulder County has done or what San Juan has done? Jordan and I had a conversation earlier today where we tried to talk about how to be prepared for what could come next. And that includes just having the, if we need to become more clamped down, we'd have the documents in place and the public health order in place so we could execute if we need to, if things start moving more quickly after this meeting, say. But I'd like to hear from our board if we could. So Dr. Giesel or Dr. Kurt or Dr. Siebel, I haven't heard from Jeannie today.
Hi.
So just inviting input and from everyone else as well. Thank you.
So I think that we have a great level of vaccination amongst the locals, but our county is different because we have a lot of visitors who are not vaccinated. And vaccination is the best tool as well as masking. And I wonder if there's been conversation about checking vaccination status for restaurants, which a lot of places have started. I was in New York City and they checked my vaccination status everywhere that I went. So that is probably another tool.
Thank you. Throwing that out there, Dr. Kurt.
While enforcement can be an issue with indoor masks, I would strongly suggest that in public buildings, such as Pitkin County buildings, city or town of Aspen, city of Aspen, town of Snowmass buildings, that masks be required because you're dealing with governmental buildings and such can be enforced. In the non-enforceable areas such as restaurants, shops, etc., I can see that that's a recommendation, not necessarily a requirement.
Thank you. I don't see everyone here, but I'm going to look for people.
This is Krista.
Krista, thank
I
you.
just wanted to kind of second, what Jordana and Dr. Curtis just said, that I think enforcement's a problem we had last year. Enforcement's going to be a problem we continue to have, and to put something as a mandate that we clearly state we're not going to be able to enforce, I think sounds a little odd. I would really like to hear from Tori and Bill about what their thoughts might be about some of this, citywide mask. Would they consider that Dr. Kurt has just brought up?
I agree.
Great. Thank you. And, before we put Tori and Bill on the spot, I know they're here and they probably have something to say. We did talk about a possible middle ground earlier, and that would be a signage posting requirement, because I guess we've heard that many people, believe it or not, didn't know there was a problem when they came into town. And Krista and I discussed this earlier, would putting an order in that we actually post in front of every building, as we have the right to, I believe, a sign that tells people what our strong recommendations are and how well would that go over. And part of this is really about trying to relieve the waitresses and the waiters, the frontline greeters and service workers from being the enforcers. That's not what we're trying to do. What we're trying to do is support them. So I don't know, Tori, do you want to weigh in here? Bill, I don't see you, but I know you're here.
Yeah. Let's see. I think there's some information that still could be shared. Talk about percentage and actually Josh had a great slide, but we were going so fast earlier that I couldn't really absorb a lot of the information. So slide one that Josh was showing, the one before the fatality slide, I thought had some data there. I'm interested in what the percentage of breakthrough cases are. I'm really happy that our vaccination info shows that we are at 90% here locally. The comments that I get from businesses are that a mandate would be more helpful to them. Recommendations don't seem to be anything that is carrying much water for them. I'm hearing our hospitalization numbers, and I thought that that was kind of a trigger for us to kind of move in a direction of mandating masks. As far as enforceability, I don't know who's enforcing. We never really had much enforcement by the county or the city prior to this, so I think it would be the same. I don't think looking at enforcement as a reason to not do something is really that valid. I'm concerned about my community's health and safety. And if we agree that masking increases the health and safety for our residents, then I am for it. I currently have a city council that is somewhat split on this issue, and they are asking me for more information and data. The hospitalization information is one of those things that they're interested in. What I've heard is that our area hospitals, where we would be getting our patients to go out to, are facing 20% capacity availability right now, and that's a concern. When I hear that our local hospital is also now seeing some of their ICU beds being utilized 2 out of 4 for COVID patients, that's of concern. Again, I put the question to this group. If we agree that masking is one of the things that we can do to maintain health and safety for our residents and our visitors, I'm surprised that we're not moving in that direction. We are probably a week and a half late on this. We probably should have been in place with it going into this busy month of September, where here in the city of Aspen, we know that we have several events that are inviting outside guests and visitors to our community. So we're in a very difficult position. The timing of this is now making it even more difficult. For me, I'm supportive of whatever makes the health and safety of my community first. That's where I sit with it. I was hoping to have a little bit more time for this part of our meeting. I think this is probably the most important thing that we are talking about right now. Having more than 5 minutes for this discussion probably would have been good.
Great. Thanks, Tori. I appreciate it. And I share your sentiment. I apologize for the rush. I think we just tried to pack too much information in today. And I'm willing to go over. I don't have to do the hard stop at 3:30. If we can go to 3:45, maybe that'll help. If you can all give me a head nod, if you can do that with us. But moving right along, I see Dr. Levin has a comment.
Yeah, thanks. I applaud Tori's comments. I would put a strong recommendation into looking at the Boulder policy and following suit with that. I think there's a caveat in there. It says that if there's a 100% vaccination level in a business, that they can opt not to have indoor masks, I believe, but I don't know the full details, Jordana. But I think that we should look at that now. And
you hear me?
Considering I don't think it's too late. I think it's never too late. There are 7 states currently that have followed CDC guidance on this. We are in a county that is in the highest incident rate in the CDC guidance. And if we align with the CDC, we simplify things, we provide clarity to businesses, we have a consistent message. It makes it very simple and easy in terms of policy. Now, I know Dr. Geisel, the whole issue with enforcement, there's always an issue with the enforcement. I think if we allow that not to let us make steps forward to improve safety and decrease transmission, that we're making a mistake. So enforcement's never going to be 100%. We can do our best. And
don't get me wrong. I don't want to be the person that comes across saying I don't support this.
Oh, well, okay. I didn't mean to yeah, I think you noted it, but I know that there's a general conversation about this, and that's one of the big arguments against doing it. And I completely appreciate that. And while I appreciate that enforcement is a really important concept, I think in a case like this, we have to say, let's do our best. We're not going to be 100%, but at least we're going to improve safety. And that's the goal, and improve the health of the community. And so I think it's where all the states are going. I anticipate this happening throughout the fall, that this is going to be a domino effect. And I think we should be a leader and follow Boulder. Anyway.
Great. Thanks, Dr. Levin.
I completely agree. And as a doctor, we wear masks obviously all the time, and every patient that comes in to see me, I mean, I clearly support masks indoors and I wear them myself, and I really would like, I think it's the right thing to do. I just think that if we are going to do this, we need to put enforceability on the table so people can hear that and understand that we may not have the means to enforce it. And we didn't last year either, and it worked, and that's okay. And I think too, there is some caveats we may need to consider, which is Belly Up, for example, has used this vaccination thing and been successful. So instead of just applying a broad mandate, there may be a few things that we want to tease out. I really would like to hear from Bill too about snow masks at some point.
Thanks, Bill. You ready to talk to us about comments?
Yeah, I'd really like to see a cultural shift. I think that, if you look to places like Asia, masking is something that goes on there. And it's not just about pollution. You see farmers in the field wearing masks. I mean, I think that people who've raised the concern with me, I just encourage them, put a mask on. I mean, we saw from the slides there, that's obviously going to be a benefit. So I think, part of our messaging needs to be just mask up, and particularly if you are concerned or if you're immunocompromised, put a mask on, and let's make sure we're protecting ourselves to the best of our ability.
The question would be, how do you think the snowmass community or your council would respond to a mandate if that's what I'm hearing is that maybe we need to be stronger than just the recommendation.
Well, I don't think I want to speak for my council until I discuss it with them, but I think it's obviously a topic that is on the table, and we should kick that around.
Right. Thank you. So maybe by the end of this meeting today, we could charge our public health director to be able to make the call as necessary. If we see our numbers declining, we need to be ready to move quickly. And as some say, we're not moving fast enough yet. So I see there's a question from Ann, but I wanted to come up. We need a suggestion on how to move forward so that we can be responsive and not have to wait to the next public health meeting, of course, or even the next public health special meeting if we need to take action. I want to be able to charge Jordana with the ability to move forward, and what's the best way we can do that. And while you're contemplating that, Ann had a question.
Yeah, and I'll make this quick because I know we're running over and it's pretty late over here. First of all, I want to thank the staff. It was a long presentation, but I think important for us to understand the situation we're in, which is, if you look at it, is dire. I mean, we have 9 times the transmission rate that we did this time last year. I'm in Britain right now, which has the highest transmission rate of any European country. And every place you go, masks are mandated. Now you have people that don't wear them and they don't get chased out of the shop, but requirement versus recommendation. Requirement allows the businesses to put up the signs to at least say you need to leave our shop. It enables them to protect themselves. I also think this is what we're going to be dealing with in the future. And we're heading into a season that's going to look like it's going to be maybe worse than last season. We need to get this going right away and get people used to the idea that they need to be wearing masks and to protect ourselves. And, when we see the charts that the majority of people sick are visitors, and we can want to take care of ourselves. So anyway, I think staff should look into mandatory mask requirements as soon as possible.
Thanks, Ann. And it sounds as if what Bill is talking about regarding a cultural shift, this may be what helps us jumpstart that cultural shift. Okay. Other Dr. Kurt?
Tori has pointed out we may be a week and a half late because we're just in the period of incubation from the Labor Day weekend. So this is probably going to get worse before it gets better. And so I think implementing a kind of mandatory mask at this point, I realize that there are enforcement issues, but you can require a sign to be put at the entrance to shops or on the window to back up the shop owner in enforcement. So I move that we begin a mandatory mask program for Pitkin County and implement it with the store shop sign and other accoutrements that Tori had recommended.
Can I
Thank
add
you,
the
Dr.
caveat
Kurt.
that if you have 100% vaccination rate, they could be immune from that requirement?
That's a great suggestion. I haven't seen the Boulder County rules. I'm not sure how familiar we all.
Provide the slide with that, Greg, and see if
Please, please do, Jordana. And then let us know what you would need from us. We have a motion on the table. We can look at this and then we'll see if we have a second and move from there.
It's a couple slides in, Lindsay. It says Boulder County at the top. Keep going. 3, another one. There you go. So Boulder County's indoor mask requirements, some of the highlights here: it requires mask wearing in all indoor public spaces for all individuals 2 years and older, regardless of vaccination status, during substantial or high transmission. So this gets to the point that was brought up. We should tie this to the CDC levels. It outlines that you would go into this indoor mask requirement after 5 days in the substantial or high levels, as indicated by the CDC model, and that you would come out after you have been in the low or whatever the medium level is, the number level 1 or 2, according to the CDC, for 21 days. Then this mask order would not have to be followed. It also lays out that there's a process for becoming a fully vaccinated facility. Includes self-attestation, the opportunity for inspection and connection, and that for these facilities that can attest to the fact that they are verifying the fully vaccinated status of everyone indoors, masking is not required when those conditions are met. Those are the highlights of that. To everyone's point, it also requires posting of signage on your business, and several other things that have been pretty consistent with the mask mandates that we've had in the past. So this, I'll pause there, and those are the highlights of what Boulder County has implemented.
Thank you, Jordana. So if we were to institute this today, if we vote on this today, we'd have 5 days of this high, I guess, the caution level at the hospital, or what the CDC level, which would put us when would this go into effect?
We already meet the criteria and have met the criteria. So it would be up to the board to set either a date or another criteria for us to begin our own implementation of a mask order.
What would be the soonest you could implement something like that to give you enough time to put that together?
I think that realistically giving us a week to be able to draft the order, let businesses know, come up with signage, and then also come up with a process for those that are able to meet the criteria for 100% vaccination verification, would be the quickest time period that we'd be able to realistically do that in.
Okay, if I could, just regarding the current festival schedule and the activities, I'm getting texts right now from people who are saying, just do this. And so I think given food and wine and rugger, whatever else is coming, that is something where we may not want to just wait a whole week. Can we have, how soon could this actually happen if we had to move very quickly?
I mean, I can write the order tonight, and we can send it to as soon as it gets reviewed by the attorney. What's going to get lost in that process, I don't know if Tracy's still on the line, is just the ability to communicate that out. But we've all been through the changes, the rapid changes throughout COVID. So it's up to the board to decide if a less smooth communication process is the benefit of getting that mandate in place sooner if it outweighs it.
Great, thank you. And I think we are accustomed to the less smooth communication, just because, as you said, this is how we've been rolling through the pandemic. I saw a couple of other questions. I just want to point out we have a motion from Dr. Kurt. We need a second, then there's always room for more conversation.
I will accept the amendment of the Boulder County and CDC provisions described.
Thank you. Do we have a second to that? Just to keep us on track here, and then I'll still allow further conversation before we take a vote. And I'm not hearing it or seeing it. If you want a second, okay, now I see Jeannie, and I'll give it to Jeannie. Jeannie, okay, Krista, you got
it. That's cool.
Thank you. And a third from Krista. Okay, for further conversation, I want to hear once again if Tori and Bill want to weigh in, because I know they're on the hot seat, and anyone else as well is welcome.
So the first thing that I would add to it is, I think a good example here is the belly up. So what I saw in the Boulder regulations was about a fully vaccinated facility, meaning maybe the employee vaccination, or the employees are fully vaccinated. But you know, I'm comfortable working into this a provision that outlines a venue such as this, events even that have requirements in place. I don't necessarily. What I'm saying is, you know, with the belly up protocols that are in place, I don't see the necessity for their audience members to be masking as well if they're all required to have vaccination proof, affidavit, or the negative test result within 72 hours. So I can see there being modifications to this that are more accommodating to what we're doing here. So you know, I feel for Jordana in this situation where she says, you know, to get this right and to get it communicated correctly takes more than this 5 minutes that we have in this meeting. And I think that there are things that we can do to make this effective in our community. And that's the conversation that I wanted to have today, to make it really appropriate going forward, to make it something that's implementable and effective. And I don't know that we're there right now.
Okay. Thank you, Tori. I don't know if you just saw, I just saw a text from Michael Goldberg saying now is the time to require this. Requirement now is the smart move, is what he says. Belly up is 100% vaccine required. And so I think he's saying it's time to do something. And it seems as if that's, Michael, I'm sure you're listening. I don't want to misinterpret it, but your text was so quick. I don't want to misinterpret it, but that's what I'm reading fairly unequivocally from Michael. Okay, any other comments here?
I noticed Food and Wine is testing everyone. So they had a testing tent right outside of the Wheeler, as I was at a Wheeler board meeting yesterday. So
Right.
Food and Wine is prepared.
Now they're doing that. They're also in a unique situation where you can't really enjoy food and wine if you have a mask on 100% of the time. So
I understand that if they're testing everyone and they're negative, I'm okay with that.
right. It's a tough one. Dr. Levin.
I just believe the simpler and more concise policy, the better, just to clarify and not make things confusing and have different caveats. So the more in that direction, I think would work the best.
Thank you. I appreciate that. Other hands? I'm going to look through anybody else here that if I haven't seen.
Greg, I would just ask that we can also come back to the timing conversation now that we've kind of discussed, you know, Food and Wine has protocols in place for this weekend. The majority of that is going to be outside in open-sided tents. Can we think about, you know, that if this is a policy that we're saying we need to do it, we want it to be done right and communicated correctly. Can we give ourselves a little time to make sure that we communicate out what the policy is, make sure it's correct and as good as we can make it the first time around, so that we can roll this out in a responsible way.
I think that makes great sense and good points made. It would also give us time for Tori to be more comfortable and perhaps ask some questions as you're crafting that. And it seems as if we would then say, we're going to give it this week or 5 days or whatever. I guess that's something I'd like to give you the authority to decide when. Personally, I think this board can say, yes, let's do this, and let the public health director make the call.
And I think the criteria that I would suggest using is, you know, looking at the hospital capacity. Every Wednesday, we meet with the hospital and address hospital capacity. And if we are not back into our green, smooth sailing, no problems capacity, that we would implement it following that meeting on next Thursday.
Right. Thank you. And I think this is the way it should work. It should be Dave Ressler and you having this, you know, processing this information and making that call. Okay. So I think I have a motion. I had an amended motion. How I want to make sure I'm not missing something. I want to make sure that's clear to Jordana, and it's what we all intended. So a little bit more just to clarify, give me the confidence that this is the vote we want to take to really empower the public health director to implement a mask mandate in the next week, if that's still it. and based on the available data and with the support of both our board and it seems as if a good sampling from our community, businesses in the community in particular.
Yeah, Greg, and if I could just, if I could real quickly, I really appreciate what Jordana just said about the hospital capacity, because this board, going back even about 2 months now, has really been talking about using that as our primary indicator, our primary metric for our precautions in our community. So I can respect Jordana's desire there.
Great, thank you. And I just found John Peacock on the call, listening in. John, you are my policy go-to protocol guy. Do we need to articulate this vote any more than this, or are we just voting to empower Jordana to move forward with a mask mandate?
Yeah, it sounds like at this point, the board's motion, and just for clarity, is to direct Jordana to execute a mask mandate based on hospitalization data, and that the mask mandate would likely not go into effect until next week, next reporting period of the hospital data. And at that time, what may go into effect, it sounds like, is really a triggers for indoor mask mandate. And so I do concur with Jordana's concerns that we really need the community to be partnering with us to make this successful. And so going a little slower to be able to communicate may actually be going faster to get the mask mandates in place in that regard. And so, yeah, as I understand, as long as the board is understanding the motion as directing Jordana to basically establish those metrics, and by next Wednesday, if those hospital metrics haven't changed, we would likely see an indoor mask mandate coming through a public health order.
Thank you, John. And Dr. Kurt?
I'd like to point out, so we're sure what we're talking about, that the CDC and the Boulder County guidelines are not solely hospital-based. There are case positive rates and the SIR, the standard incidence rates, involved as well.
Great, thank you. Okay, I think I'm ready to call this question. And so I'm going to ask for a vote. All in favor, raise your hand, right hand. And I'm going to scroll here. If anybody who is opposed, I want to see their hand as well, because I want to make sure that we're getting an accurate count, and I'm going to count on Suzuho to help me make that count if she's here, or Jordana. I think we have a unanimous vote. We have a consensus that this is the strategy. Thank you, Jordana. And I know we've run over time. Would you like to give us a preview on preparedness going into winter any more so than we have already, so people can anticipate and the community can understand that we're going to be preparing the community for what may this winter regarding protocols?
Thanks, Greg. I think that in October, we'd like to come with any additional recommendations for us to consider. We're continuing to work with ACRA to pull together some task forces. I think it was Jeannie who had the idea about restaurants, and just being sure that we're playing first and foremost that educational role of letting our community businesses and organizations know what the options are, within the prevention tool bucket that we've got, and then seeing where there's interest, and then also continuing to watch our numbers. We'll have 3 weeks of data, I think probably come our next meeting. If we do go the mask route, seeing if that is able to tamp down any of the so the hospital capacity issue, and see if our incidence rate changes then. But just to let everyone know that that winter planning conversation will continue, and we'll plan to bring an update to the board in October.
Great, thank you. Dr. Gill?
Thanks. I just had one last comment too, and I wasn't exactly sure where this fits in, but David Baugh did send out a communication from the school district yesterday about the mitigation strategies the school's using. And on there, it did mention that the public health was going to revisit or the Board of Health, excuse me, revisit the mask order that we did for the schools October 1st. I don't think this is our next meeting is probably not going to coincide before October 1st or come before October 1st. So I don't know if we can discuss this temporarily right now or not, but in light of our other conversation, I don't really see that going away before October 1st.
Thanks, Krista. That at the school, it's aligned also with the CDC guidance, so that if by October 1st, we are in the low or the moderate, I think is the next level, that's when it would be revisited. So if that is the case, we'll figure out a way to be able to have that conversation and let the Board of Health know what's going on.
Thanks, Jordana. Tori?
And then Jordana, I suspect that prior to next Wednesday's actual meeting with Dave from the hospital, you'll be hearing updates and other data over the next several days as well. So, if on Monday and Tuesday you're seeing elevated numbers that are of concern, then we should be looking at moving that forward.
Great,
Okay.
thank you. I wanted to make that point as well. A couple of points of business here. I just had a note. Michael Goldberg say, I'd read his text. He wanted to make sure that we understood he was speaking as a restaurateur and not as an ACRA board member. He's not speaking for the ACRA board, but he wanted to make that point clear. So I've done that. The other thing regarding our October meeting, I think we need to have mechanisms in place to alert visitors coming to Aspen well in advance of their trip to Aspen or even booking it, that, if we may have these protocols in place. So this is going to be signage that they're going to see at the airport, and they're also going to see when they make their reservation with the hotel, because we want to try to stop the COVID from even coming to the community at all, or booking a reservation if we can. So that will be part of the conversation in October.
Let's get this out in the media so people can anticipate it next week. So
that's what we've been talking about, and we're going to be working on that as we go into October. Does anyone else have anything else? Our next meeting is October 14th. I realize I owe everybody 21 minutes of their lives for going over, and so I apologize for that. We'll try to make it shorter next time. Anyone else want to chime in before we log off today?
You might have just given us all 21 minutes on our lives, but
Yeah.
you just did. So.
Thank you. Let's hope so.
Let's adjourn.
Okay, we have a motion to adjourn if we need one or not. I see a second. Thank you all for coming. All in favor, and we'll see you next time.
Thank you,
Thank you,
everyone.
guys.
Thank you.
Thanks a lot.